website after the event. So if you're asking questions, just know that that's the case. But we also want to encourage everybody to be participatory. This has been as a useful exercise for legislators and staffers alike. So if you have questions throughout, please ask them. If you're in the room, raise your hand. If you're on Zoom, if you want to put something into chat or use the hand raise function on Zoom, we can call on you. You can ask those questions live, or I can ask the questions if they're entered into chat of our presenters. We will stop folks throughout to make it conversational and helpful in that regard. There's some coffee and pastries in the back for folks who are in the room. There's also restrooms out in the hall. If you didn't know where those are, you can ask somebody. But please feel free to get up and sit down throughout the morning. So we have three hours of presentations to get to today. But before we get there, I'm going to turn it over to our director, Sue Birch, for a couple of remarks, and then we'll get started. So thanks.
Where is best for the camera and filming? Is it over here? Right there. Sit down, she says. Good morning, everybody. Thank you, Evan. A huge shout out to Evan and the team and Michelle for putting this together, second year. And I think also for those of you attending in person and hybrid, thank you for participating. This is really important work. I'm Sue Birch. I'm the director here at the Healthcare Authority. I think many of you know me. I'm a nurse by background, but have my business degree and work closely with our senior leadership team and all of you. We really look forward to this very collaborative conversational event today. It's really important that we keep aligned and invested in all the great work that our state continues to manifest. And there's no shortage of need, as you very well know. And it's also really critical that this continue to be a very close collaboration with the legislature, all of you, and obviously our federal partners to a degree as well when it involves federal funds. It's a really valuable opportunity to have this conversation on topics that both the HCA and the legislature have really deemed as critically important, and we want to continue addressing these things. And now more than ever, with some of the challenges that have hit us in the past years and we are experiencing, really require us to lean in and keep addressing the highest priority areas. So for today, we want to focus on those high priority areas, the top priorities being community behavioral health capacity and helping people understand the importance of those amenities and services that have to happen in order to balance things out for better well-being. We also want to address the opioid and fentanyl crisis because, as you all have heard and know and are experiencing, this is continuing to be a kind of a trend and a worsening event that is really requiring all of our immediate attention and resources. We're going to take you into a deep dive into the Section 1115 Medicaid transformation waiver renewal. And because we have a need to move with speed, we're going to call that MTP 2.0 for Medicaid Transformation Project. We're going to try not to speak too much acronym language, but that one's important because MTP 2.0 is a key initiative that lets us innovate and transform and keep moving the state in a better direction. And then lastly, and probably most dear to my heart for this next year, is healthcare affordability. So we're going to take you into kind of some of the data and the richness of all that we're learning about cost containment efforts around the country and why affordability is something we have to continue to move aggressively on. We've heard from you that these issues are top of mind, that these are things that constituents are pushing on legislature about. And we know that as we move into budget and policy decisions in this upcoming legislative session, it's always good to tune up on all that's happening because in these four areas, there's a lot that keeps evolving and happening. And really, it's just important to stay in tight connection with you. I do think it's really important to note that these just represent a little piece of what we do. While these are some of the big drivers, please don't forget that we are still dealing with the the public health emergency unwind. We're dealing with massive consumer involvement. We have lots going on with our exchange partners. We have so much going on with our other sister agencies. There are many, many, many other projects that are top of mind for us and that we can't let up. I remind you, investing and maturing our use of information technology, really important as we have to modernize and meet those federal requirements. We also have to continue to really pay attention to the purchasing and oversight of employee and retiree benefits. Lots happening in that Medicare Advantage space. Welcome, Molly from the governor's office. Dave back there, there he is, our director, will take us deeper into some of this later on. We also wanted to talk about, we want to make sure that you know that we are also really investing and continuing to expand the thinking around primary care and care coordination efforts. And there are so many, many other initiatives that go on. But today, we're focusing on those 4 that I mentioned above. And then you'll be hearing about these other areas, I know, as we continue to move through session. Our commitment is that we will continue to share our successes, that we'll be transparent about our challenges, and we'll continue to collaborate with you to ensure that the people of Washington have the opportunity to be as healthy as possible. So we simply have to work with you, right and left hand, knowing exactly what we're up to. And so that is our pledge to you. Your investments in our programs, including behavioral health, the Apple Health expansion, all the myriad of IT initiatives have been so appreciated, and they're so critically important as we inch this transformation journey forward. I remind you that with you, we have increased access, we're driving affordability, we're improving the health of all your constituents, wherever they reside, and regardless of their cultural, ethnic, or economic background. I was really pleased to get a call on the work that you seeded several years ago about continuous eligibility. The American Academy of Pediatrics has now called to replicate what you authorized us to do, which was to keep those kids eligible on Medicaid from 0 to 6. And there are now many other states in the pipeline to get those approvals. So I remind you that you are leaders in this health transformation space with us. And that is critically important. There are so many other kind of firsts or kind of lead initiatives that are helping kind of the US look at how do we keep transforming healthcare. We also know that there's a lot more work that's necessary to ensure that everyone has the access to care they need at prices they can afford. And we look forward to working with you and being a resource for you throughout the next legislative session. So I'm going to stop. We're going to dive in, and I'm going to hand this back over to Evan. And thank you again for all of you being here. And please enjoy those goodies over there because they are really great.
Awesome. Thank you, Sue. And Sue did a great job of setting the stage for today. As she noted, there's a ton going on here at the agency. So I think we're really planning to scratch the surface in terms of the breadth of work that's happening here. Deeper dive into 3 of the topics, obviously, that we're going to focus on: community behavioral health and our response to the opioid and fentanyl crisis in the state, some of the work that's happening around our 1115 transformation waiver, and then hopefully a conversation to finish the morning around healthcare affordability and the work we're doing to support consumers in their access to health insurance. So again, I just wanted to reiterate, we want to make this conversational today. For folks who are online, and I think we have over 40 participants who are joining us through Zoom, please do use that chat function to ask questions. I'll be here to prompt our presenters to be responsive throughout the presentation. And then for folks in the room as well, please do raise your hand and join us in the conversation on these topics. So we want to make it really useful. So I want to call up our first panel that's going to talk to you about some of the work that's happening in the behavioral health space here. We have our behavioral health director, Carrie Waterland, with us this morning, as well as her 2 deputies, the Deputy Division Director of Behavioral Health and Recovery, Michael Langer, and then our Deputy Division Director of Treatment and Recovery Programs, Tisha Kirschbaum. And we are also joined by our State Opioid Administrator, Chris Shera. And they're going to talk to you kind of a 2-part presentation about community behavioral health and opioid and fentanyl issues. So
you, Evan. Good morning, everyone. How's everybody doing today?
Good.
Right.
Doing good.
Thank you. I think we needed that because just, sit down, relax for a sec. With the stuff we're going to talk to you about today, we decided we'd start on the lighter note, right? Community behavioral health and opioids. So good morning to everyone. And just know that everything that we talk to you about today may feel heavy, may have a heavy tone to it. And that's kind of where we're at. So let's dive in today, starting with community behavioral health. Next, who's doing our stuff? I guess me. Perfect. No. How about this one? Maybe Julia. We're going to figure this out really quickly.
Super glad we're already recording.
Me
as we
too. All the 40 folks on the line. Hi. Wonderful. So for the record, right, for folks in the room and for the record, and for folks on Zoom, thank you for attending, all 40, maybe plus of you now on Zoom, and folks in the room. My name is Carrie Waterland, and I am our Division Director of the Division of Behavioral Health and Recovery here at the Healthcare Authority. And here with me today is Tisha Kirschbaum. As Evan introduced her, is our Deputy Director of Treatment Programs and Recovery Support Services. Today, you are going to hear just a little sliver of some of the things that we do in community behavioral health. We know, and many of you know, that the community behavioral health system is really broad, and it means a lot of different things to a lot of different people depending on who you ask. So we are not going to be able to touch on all of community behavioral health today, but we will focus on some topics that we think that staff and elected officials are probably going to be hearing about or have been hearing about from their constituents. And so those two things are how to serve people with behavioral health needs successfully and well. And then the second piece, as you heard again, is the opioid and fentanyl epidemic and a background response to that. So we are not going to talk about beds. We are going to talk about some other really important things though. Next slide, please. So today, as we are all thinking about the topic of community behavioral health, when we talk about community behavioral health, we're referring to this network of behavioral health agencies. You may have heard them referred to as BHAs, and providers who are in the community. The folks that we're talking about today and the programs we're talking about today are intended to serve individuals with high needs, but with needs that can be addressed in the community, meaning not necessarily an institution or a bed. These services, as we're talking, include things like outpatient services, intensive outreach, and in some cases, residential programs, which are not the same again as kind of institution-based programs. We know that if the system functions well, and why we're talking about a lot of these pieces today with you is, we don't have to rely then on the much more expensive back-end services that are kind of at the very tail end of our community behavioral health system. We also know, and research shows us, that if we wait to provide services in an institutional setting, those are more intrusive, they're less therapeutic, and getting folks back to a baseline of being able to work and play and live and recover in their home community is much more difficult. So some of those examples that we are not going to talk about today, that we're really trying to triage away from, are things like hospitalizations, ER visits, and jails and prisons. Next slide. So we do often talk about beds in the community, and we have a feeling that beds may be a topic of conversation this next legislative session. They are a critical component of a functioning behavioral health system. We absolutely acknowledge that. They are also best when other parts of the behavioral health system are functioning well and are strong. And so in short, beds cannot function in isolation. They are often the answer to a system that is not functioning. So it's important to remember that our inpatient beds are not where folks are intended to live long-term. They are intended to receive treatment and hopefully go back to the community. The system really, really should, and what we'll talk to you about today are some things that will help move folks through the system into less restrictive settings. Outpatient services cost less than inpatient services, we know that. And they are where most folks that we've talked with really want to receive services. People want to live close to family, friends, and natural supports, just like all of us, right? And it really should be where folks are receiving behavioral health care, just as the same where folks receive their physical health care, right? You go to a doctor that's in your community to receive your physical health care. Sometimes you go to a pharmacy if you receive a vaccine to receive a vaccine in your community. So just things that are a little bit closer to you. Outpatient services result in lower financial costs and lower social costs. And what we mean by that is there's less disruption to the social fabric and to communities. When you don't have a crisis, but you have something that's really addressed at a low acuity kind of intervention. If we better invest in community-based services, then we really, really can start to turn the tide and prevent and reduce the frequency of deeper utilization, such as hospitalization. We can extend the amount of time that folks remain in the community, and we can utilize the outpatient system and natural supports. And so I've said that twice. And natural supports are those things that everyone has, right? Friends, family, a job that you love to go to, things that are meaningful to human beings, right? We all have them, and they just work better when our natural supports are close to us. Have you ever had to try this long distance relationship thing? It's possible, but it's also really challenging, right? Throwing it out there so that folks know a little bit. Okay, so next slide, please. Thank you. Community behavioral health agencies, or BHAs, are crucial providers for people living in the community with serious mental illness. In recent years, they've lost workforce, but thankfully, you all have provided a ton of infusion into the community behavioral health system, specifically aimed at stabilizing providers. So thank you for that. It's absolutely necessary. And wanted to just kind of tickle your memory. You all invested roughly $5.1 billion in the community behavioral health system. And we thank you for that. So some of those investments that you made are Medicaid rate increases around a 9%, and then an additional 15% rate increase that goes into effect of January of 2024. $130 million that I kind of talked about a little bit before in provider relief funds that are really targeted towards stabilizing the workforce and really how can we recruit, how can we retain workforce in community behavioral health. There was also the creation of the Joint Legislative Executive Committee on Behavioral Health, or JLEC, from here on out. And the workforce kind of crisis really is in that scope and that capacity, which is wonderful. There were also bills that were aimed at streamlining and aligning licensing requirements so that we could really infuse the workforce quickly and see if there were ways that we could kind of cross-reference things. And so we're thankful for the ability to partner with the Department of Health on those and see what we can do to get more folks into the community behavioral health workforce. And lastly, I think if you've heard me talk before about community behavioral health, it wouldn't be a community behavioral health presentation unless I touted Start Your Path, all one word, .org. Maybe you want to become a community behavioral health provider as a second career, third career. People are doing a lot of side gigs. And with the creation of our ability to know that we can strike rapport in a telehealth environment, that we can reach and connect folks who maybe were not able to leave their home before, we're really able to reach more and more. Evan.
Didn't mean to stop you there. I just wanted
to. Please do.
I wanted to note in the Zoom chat, Representative Davis just kind of made a comment about some of the benefits of recovery cafes and clubhouses in this space. So I didn't know if you wanted to say something for a moment.
I do. I'm also absolutely going to say that Tisha is a bigger expert on those things, and I believe that there are pieces of that you may touch on in your presentation. So Representative Davis, if we don't get to it in our presentation, we will answer and talk a little bit more about those as we weave those in. Is that Tisha's saying, yes, we are absolutely going to get to those, everybody, so hold us to that. Any other things, Evan, before I need to really pass this on to the subject matter expert in content? Okay, perfect. So with all of that in mind, I'm going to pass this on to Tisha to talk about some of our programs, and then we're going to end with some opportunity for questions, but we will stop, Evan, throughout the entire presentation and are happy to take any questions as we move along. So with that, Tisha Kirschbaum.
Good morning, everyone. As Carrie introduced myself before, my name is Tisha Kirschbaum. I am one of two deputy directors here at the Division of Behavioral Health and Recovery, and kind of in my portfolio are many or all of the programs that are really connected to individuals after they've either had a diagnosis or kind of services begin, or we've identified that services are really needed. Thank you, Representative Davis, for bringing up recovery cafes and also clubhouses. I think they are both wonderful examples of the type of services that help people stay healthy in their community. They are really the types of supports that happen outside of a treatment environment and really ensure that people can be well connected to their communities, be connected with friends, get supports to find employment, and also just the ongoing supports that are needed to form community. And we all know that community is a huge part of individuals maintaining their recovery. So thank you for bringing that up. One of the specific programs that we really wanted to identify and talk about today is PACT. So programs for assertive community treatment. So PACT is an example of an evidence-based program specifically created to support individuals with high levels of behavioral health needs in the community. So earlier, Carrie referred to intensive community-based outreach services. PACT is a wonderful example of this. We often refer to PACT, you might have heard of it called this before. It's often referred to as a hospital without walls. We also know, and evidence shows, that when PACT is performed to high fidelity, it does reduce hospitalizations. Something we did want to point out is that PACT programs have taken a hit during the pandemic and need special support to restore their previous level of operations. Partly this is due to the nature of their work, which is really serving individuals with very high level needs in the community. So it's not a service that typically is performed in a clinic setting or in a treatment setting, but the service providers really go to the individuals where they live, provide that level of support to them in their community, in their homes, so they can stay successful. This is a map that shows where PACT teams are currently located across the state. So PACT began in Washington State in 2007. In the past 5 years, there has been significant investment to expand our PACT teams. Thank you. We know that additional funding and teams are needed to be able to serve the number of people who would benefit from PACT services. This is specifically referenced in a recent PACT needs study created by RDA and the University of Washington. So currently there are 21 teams in Washington State, including 16 full teams and 5 half teams. So if you take a look at the little legend at the bottom of the screen here, our full teams are marked with a diamond and a half team is in a triangle. We're also excited to announce that we have 2 new teams who joined in 2022, and they are in yellow. So in addition to the need to increase capacity, we've also noticed a need to stabilize our current network. Because of this, a decision package has been submitted to address our PAC network stability and support expansion to meet the demand. we are asking for the following things: a funding increase to the teams to provide wage increases to pay differentials and allow other incentives to make PACT positions competitive in the job market. Provide some additional one-time 6-week ramp-up funds to the providers to kind of rebuild their capacity. Funding for additional teams to expand the network. Ongoing support for the University of Washington, who really provide the critical technical assistance and fidelity monitoring and review for our PACT teams. Requesting FTE to support expansion and oversight. And lastly, funding a needs assessment to look at forensic assertive community treatment. So another example of how to support people in the community and reduce the need for hospitalizations and inpatient beds is intensive residential treatment. So intensive residential treatment is a team-based model. It's very similar to PACT, but it serves people living in ALTA facilities, and it's currently piloted in 3 communities. It's important to remember that with PACT, they focus on individuals who are not in institutions. This is a slight twist, and it's really providing the supports to individuals who would be living in an ALTA facility that might also benefit from this kind of intensive behavioral health support. We are very excited to announce that services will soon be available in King County to serve the IDDD population. Right now, we currently have 3 teams, 3 IR team or intensive residential treatment teams that are piloted in 3 communities across the state. This is in Lewis, Spokane, and Pierce counties. When I consider intensive residential treatment, I often think of it as kind of in between PACT and outpatient services on the continuum of care. So for example, where PACT is 24/7 support, intensive residential treatment is focused more on 12 to 16 hours a day, Monday through Friday, because the individuals are living in a facility-based setting and they can receive some of those other supports in that facility.
Oh, question.
Oh, good.
Hi.
Mary with DCYF. I'm just curious, are both of these models for the adult population?
Yes.
Okay.
Tisha, there was another note in the chat just around the homeless outreach stabilization and transition program. I don't know if you have any comments just kind of in regard to that program in relation to PACT or IRT. I wanted to put that out there.
Yeah, so I believe we're referring to HOST, which is a fantastic program, and it really is another example of an intensive outreach program that is part of a licensed community behavioral health agency, and they really are intended to meet people often who are homeless or have unstable living situations and get them connected to services. So I think they are another example of the type of a community-based intensive service that is also meant to help people stay supported in the community and reduce the needs for inpatient and hospitalization.
And one more question in the chat as well from Representative Callan, just in regard to, and I think following up to Mary, how and where children get served in those spaces, if there are any additional programs that we wanted to reference in regard to kids.
Absolutely. So many of you are probably familiar, or you might be familiar with our WISE teams. So I often think of WISE as the youth equivalent to a PACT team.
One more question in the chat, and we do appreciate folks for their participation this morning. Representative Sen is asking whether we can talk a little bit about services for people with co-occurring issues. So in particular, folks who might have developmental disabilities as well as mental behavioral health challenges as well.
Absolutely. I think in particular, that is why we are so excited and pointed out the fact that there is an intensive residential treatment team that is going to be opening up in King County very shortly. Honestly, we hope this month we'll be able to start accepting people, if not next month. It really is focusing on supporting individuals whose primary diagnosis is with an intellectual disability or developmental disability.
We know, right, that we see this as that first step in really, really trying some things out because we know that there's a need, and that there are certain gaps in our system. One of those that's been identified in a report from, what was it, 2 years ago, I believe?
Long-term civil commitment. Yes,
right.
We did it twice now.
Yeah. And so we will talk a little bit in the next few slides about long-term civil commitment and some of the gaps in the system around that as well, I think. And so Representative Sen, if we don't touch on some of the DD and IDD needs as we're working our way through some of that, again, happy to lean in on that a little bit more. But I do know that we touched a little bit on that in our presentation.
Just one quick follow-up in regard to the your response around treatment for folks with co-occurring issues. Representative Cowell was wondering if that is for adults only or available for kids, any of those services.
So for the intensive residential treatment team, that is specifically meant for adults. So intensive behavioral health treatment facilities. So these are facilities that provide ongoing care to individuals who no longer require involuntary inpatient services. So these are specifically an environment for individuals after they have finished their inpatient treatment. So these are individuals that no longer need treatment and support. Excuse me. So these individuals do need some further treatment and support to fully and successfully integrate into their community, but no longer at a level or a service that's provided in an inpatient setting. So these services are provided by specially trained and qualified licensed staff. Staff are available 24/7 to meet the individual treatment needs, provide effective treatment interventions, and to support the individuals in making choices that align with their recovery goals and safety plans. So currently, there are 10 projects funded by the Department of Commerce with various projected dates of completion in the 23 to 25 biennium, with additional funding round just beginning. So we're excited to say that the first facility became operational in December 2022 in Olympia. And the next facility anticipates opening in Renton sometime during the winter of 2023, with several more to follow in the upcoming 12 to 18 months. So in order to support the expansion of this new facility type, we have submitted a decision package for funding for technical assistance and training to assure that the model is successfully implemented, and funding to adequately support the startup and ramp up costs that are due to the high number of programs that are opening in a short span of time in the next 2 years.
Tisha, these facilities would be able to accommodate individuals with needs with co-occurring disorders. Is that
Absolutely.
right?
Absolutely.
So just to kind of, I think, again, give a nod to Representative Sen's ask about co-occurring. This is a facility that, as we're putting online, is able to absolutely do that supportive feature for SUD and mental health.
Correct. It really is, what behavioral health supports does the individual need to be successful and to live in the community, especially if they need just a bit more support than at this exact time that they could be successful living on their own. But really the thought is that they wouldn't live here long term. They might live here for maybe up to a couple of years, but then they're going to transition into living in the community in more like with maybe some supports or supportive housing or on their own. So, as I was just saying about housing. So housing is foundational for people with significant behavioral health needs to live successfully in the community. So put simply, people are healthier when they have a home. Additional presentations will go into more depth about both Apple Health and Homes and foundational community supports in the next hour, where we're talking about our MPT 2.0. So you'll hear, we'll hopefully be providing more information, in-depth information about those two programs for the next hour. We just gave an overview of some of the community-based services that help people with intensive needs stay in the community. Also, thank you to everyone in the chat in the room who also pointed out other programs that we didn't highlight that also help individuals stay and living in the community successfully. We do think it's really important to note that there are times when an inpatient setting is needed. When that occurs, we want to make sure that we have the sufficient community-based long-term civil commitment beds so that people can transition from outpatient to inpatient as seamlessly as possible and hopefully as close to home as possible. Recently, there has been much attention on forensic hospital beds and individuals on civil conversion orders. That attention is important and needed. We also need to ensure that the bed capacity in the community that is intended to make up for the former civil state hospital beds can meet the needs of those who do not enter the involuntary system through the competency process.
Just one quick question in the chat, and it's probably backing up a couple slides from Senator Short asking about the new, I believe, intensive behavioral health treatment facilities and where those are coming online in the state in the next 12 to 18 months.
Oh, I wish I knew that number. I could rattle it off on the top of my head. They are vastly located in metropolitan areas across the state, the vast majority of them in the western side of the state. For our next round of funding that's going through Commerce, we really are focusing on where are communities that have enough supports to really be able to make sure that these facilities are successful.
Yeah, so even though we want to focus on rural and frontier areas, there is absolutely a thought of being able to support the services.
Absolutely. It's this fine balancing of how do you ensure that people have the services they need to be successful, and because we do want to make sure that the people who live in the services are mostly from that same geographic area, you just kind of have to be thoughtful about where is a community that has enough services to support and also enough referrals to make to really kind of support that particular type of facility.
Tisha, can you explain a little bit more about the community supporting services, about law enforcement or the backup kinds of things in relationship with behavioral health? Can you explain a little bit more about why that capacity in the community is so important?
So as we are building out this new particular type of facility type, it really is the idea that people have been in an inpatient setting. They've successfully transitioned out of that. They no longer need that level of support. They do need, though, some additional support to continue to kind of grow and learn their skills before they're ready to transition on to the next bit. That means that they're going to need, there are times where they might need the supports of our local crisis system and the other behavioral health supports that are provided in an outpatient setting. So it's important when we think about siting facilities that we envision what supports does the current community already have, specifically when it comes to outpatient and crisis services or just behavioral health services, and of course also other community services such as law enforcement, to really ensure that that facility type can be well supported if there is a need to call on those type of services. The hope with intensive behavioral health treatment facilities, though, is that the level of care that an individual would receive in that facility type would not necessarily put a large drain on the other community resources. And we also know that there are times when the crisis services and the outpatient services will be called upon.
Thanks, Tisha. And then just one more question in the chat from Representative Eslick. And I think, part of this is we recognize we're not able to touch on everything behavioral health today, and our focus really was on kind of community behavioral health capacity. But I think a really relevant question, and something I know we've been doing a lot of work on, is what's happening with the workforce and workforce challenges. So I don't know if you want to spend maybe just a minute kind of touching on a little bit of that work there, but obviously Representative Eslick, happy to follow up with you offline, because there's a lot of work happening in that space that we aren't planning to cover in the presentation.
Yeah, I think, thank you, Representative Eslick, for that. There are several efforts that really were supported by the legislature the last year or two around the creation of a bachelor's level behavioral health aid, I believe. I'm not, riffing now off the name officially, but, and that's something that the University of Washington is exploring. And I was just at a summit where they discussed, they're now rolling that out to University of Washington Tacoma as part of a partnership. And so there are efforts to expand the workforce, I think, to really support some of what we were talking about, which is how do you give folks a human connection, a connection with someone pre-diagnosis, when you're just possibly struggling, like, let's face it, all of us do, with anxiety, depression, sadness, all of these like normal human emotions. How can we back some of the workforce up to be able to just sit and talk with folks? So there's the effort around the bachelor's level clinicians. There's also, there's also a lot of efforts around increasing our peer workforce, which is really should be a great point of entry into how do you walk through this really challenging system from someone who's successfully walked through that challenging system. So there are a lot of those efforts. We also have and would love to spend time. So those things we don't touch on, just shameless plug, we'd love to be invited to talk about any of these other topics at length. But we have a lot of workforce campaigns too that we are, again, I just touched on the startyourpath.org, but that we're trying to get out there to make behavioral health professions an exciting and viable option for folks. And I think we also, again, thank you to the legislature, as we start to infuse more ability to not only give scholarships, but pay for people's education in advance, that's helpful too. And those are all things that the legislature supported and pushed forward. So I think more of the same of those, but we'd be absolutely happy to spend, hours talking about workforce things as well. So I think those are just a few that we can kind of touch on in our limited time today.
It's a long-term civil commitment, also called 90 or 180 day beds. So in 2018, Governor Inslee announced a plan to reshape how and where individuals with mental illness are treated in Washington. The plan invests in community capacity to divert individuals from the 2 state hospitals in order to treat people in their home communities. We have and continue to develop community-based capacity by contracting with community hospitals and freestanding evaluation and treatment facilities for long-term involuntary inpatient treatment. The community location improves the discharge planning process and keeps an individual's friends and family members connected and in closer proximity, which we know are key elements in an individual's recovery. Here is where the contracted beds are currently located. Look for the numbers in green, and where future bed sites are planned. Those are in blue. So as mentioned, we contract with acute care hospitals who have psychiatric units, evaluation and treatment facilities, and private psychiatric hospitals. So we're proud to report that as of today, 210 beds are under contract. 245 additional future beds have been funded for a total of 455 beds. We strive to have a geographic distribution of contracted beds across the state as we value helping individuals stay in their home communities, close to friends and family. During the upcoming Commerce funding round, we are placing a high priority on identifying providers looking to site facilities in underrepresented areas of the state. So for example, Central Washington. As you can see, this is a work in progress, and there are still some areas of the states where we don't have beds. So While we have had much success in building the capacity of long-term civil commitments in the community, we have identified a need for a rate increase for all of the contracted long-term civil commitment beds in order to capture the true costs of providing this care to all of the populations who need it. Current rates are not sufficient for providers serving this population and have not kept pace with market rates and lag behind rates for other like inpatient beds. We are observing clear warning signs related to the sustainability of the long-term civil commitment network of the current per person per day funding levels, as referenced in the upcoming status report to the legislature. Rates are needed to match the service needs and to provide for the unique care needs of those in long-term settings. So it's important to remember that the individuals who are now being served in the long-term civil commitment beds are people who would historically been served in the state hospitals, and as such have specialized long-term care needs not historically provided by community-based treatment facilities, who in the past had worked with a much shorter term population. As you can see on this slide, we have detailed the new funded beds we anticipate coming online in the next year or two. And again, I just have to say, we are so grateful for these investments. As we continue to grow this program, we've identified some areas to address. In last year's legislative report titled Implementation Plan to Continue the Expansion of Civil Long-Term Inpatient Capacity, we identified a number of strategies that will allow the program to serve a broader array of individuals with complex needs. We are submitting an update to this report this year, and you may recall from last year's report, we identified the following key priorities as identified by our work. So developing an enhanced rate for contracted providers serving individuals with more complex needs, making additional training and technical assistance available to the contracted facilities, foster the development of specialized subunits dedicated to serving individuals with comorbid cognitive impairments and or challenging behaviors, prioritize contracting with additional acute care hospitals who have psychiatric units to ensure that the number of beds that can serve is available to serve those who have medical complexities, and also consider the development of a limited number of no-refuse, either state-operated facilities or spaces in state-operated facilities.
Yeah. What's the timeline for when all these come online?
Oh, in the next couple of years. So we have funding to do that, and it is an ongoing process of marketing to providers, to marketing to acute care hospitals with psych who have an ENT located in them, or current ENTs as new ones as they come online, and also psychiatric hospitals to continually accept our contracts to build out these numbers of beds. So as soon as possible.
Yeah, I think, a lot of it is also really dependent on our ability to find contractors who also have the workforce to open up and do this work. And so there are, as soon as possible, and there are certain things that as we uncover and discover working relationships may have fits and starts as we put beds online as well.
So maybe use Thurston County as an example. I read that to say there'll be 16 beds. I don't know what Recovery Innovations is. 1921, I assume, first 1921 budget cycle. Can you explain to me what that is? Because I originally read this to mean, oh, Commerce is contracted and we've got 16 beds, and it just sounds as though they perhaps haven't contracted.
That is a great example of how there's multiple state agencies who work together to put these beds online. So at first, the funding to build the capital goes through the Department of Commerce, and that was in Thurston County. That was in the 19 to 21 budget. So an organization called RII, Recovery Innovations International, won a capital award to build the facility through Commerce, and they built it. We have now contracted with them to start providing long-term civil commitment services there. They have yet to start providing the services for a number of reasons, but mostly because of potential workforce shortages. So there's a combination of, like, currently how it's operated is the money first goes to Commerce. Those grants get awarded. Either the facilities get renovated or they get built. During that time, the provider then needs to work with the Department of Health to become licensed. They also work with us and the managed care organizations and the BHASOs to get the funding for the services. So it's kind of this 3-step process before the services actually go live. You're welcome.
And Tisha, one more question in the chat, and then I may ask if we kind of think about a transition over to the second part of this panel here in a second. But Representative Farvar was asking, and I'll paraphrase a bit, but just around long-term civil commitment beds and kind of the nexus to the forensic hospitals and thinking about, kind of what's happening with transitions of patients, and if we want to kind of talk a little bit about the connectivity there. But I know that there's a little bit in the presentation that you might have planned to cover as well. So.
Yeah, thank you for that question. I think it's really important to remember that when we have a strong crisis system, when we have a strong outpatient system, when we have some of these programs that we just identified, hopefully the need for individuals to enter into the competency system will be then reduced, which will then diminish the need for additional forensic mental health beds, to put it that simply. So I think it goes to that idea of what we're talking about, beds do not work well in isolation. And how do we build out the rest of the system so that an individual, if they do have a stay, either in a forensic mental health bed, through the competency process, or through an involuntary treatment act, those are fewer and less, and instead the individuals can receive the supports that they need in the types of programs that either we just mentioned or many of you identified and brought up in your chats and your comments. So I was thinking about, because of all these wonderful questions we are going over that are a lot of time that we were planning on talking, but there's a couple of things I do want to make sure that we mention. So where are we at here? So I'm now on, let's see, complex needs. So I had mentioned the legislative report that we have now written a couple of times. It talks about what we see as critical to continuing and sustaining the vision of long-term civil commitment in the community. So for us to be able to support the priorities identified in that report, we are asking for a specific rate enhance that's needed to serve people with more complex medical and or behavioral needs, including people with traumatic brain injuries, dementia, and co-occurring IDD to account for the true cost of care, which really do address some of the questions that were raised earlier. One of the things that we're really excited about is some of the investments we have been able to put into our discharge planning, specifically around a model called peer bridging. If you're not familiar with peer bridgers are a crucial component of our discharge planning process. They are staff at licensed community behavioral health agencies who have lived experience receiving behavioral health services themselves. They meet with people while they are in an inpatient setting and share their message of hope and recovery. They form relationships with individuals and then are able to maintain those relationships as individuals transition back to their home community and begin receiving services in the outpatient setting. So peer bridgers have not been funded to serve all of our contracted long-term civil commitment beds, and their services would better support our discharge planning. Some other exciting news to share about discharge planning is connected back to our intensive behavioral health treatment facilities. So as these facilities come online, we anticipate adding them as an important discharge and transition resource from individuals who are in our long-term civil commitment beds to then they'll transition into the intensive behavioral health treatment facilities to better support individuals as they transition back to their home communities.
Okay, Evan, I heard you, and I will edit myself. We have 2 slides left on this presentation, folks. So thank you so much for joining us on this little adventure. The last thing I will say is funding complexities. Well, no, the second to last thing, Evan, I'm sorry. is funding complexities. I think we all are aware that behavioral health is funded in a different way than other things that are healthcare related. We do not get block grants to treat diabetes. They're just not sent to states to say, here you go. It's handled through an integrated health system, which is what we are about here at Healthcare Authority, treating behavioral health as a health need. However, we also know that behavioral health is not just an encounter-based system, and that crises don't happen within kind of an 8 to 5 Monday through Friday sort of a model. As a matter of fact, they typically happen outside of those hours, right? And so it's incumbent on us, and thank you so much for your foresight, but it's incumbent on us to explore funding models that work for a robust behavioral health system outside of an encounter-based or rate-based system. So we do need to challenge ourselves, and thank you for passing numerous bills and provisos that are aimed at funding and having the Healthcare Authority partner with numerous sibling agencies to not only explore that, but look at a successful way that we can recommend back to fund the behavioral health system. So thank you so much for that. The last takeaway that we really want from this portion of the presentation, and you've heard it throughout, so I'm not gonna just hit you too hard, but I will just nudge you a little bit. What's this? The involuntary treatment system, the forensic system, should not be the way that people enter into and receive behavioral health services. If we do this right and provide services when people are first noticing symptoms, when people are first noticing feelings, just as when you get a sniffle, you go to your primary care doctor. Let's make it acceptable for folks to go to a primary care doctor, get a screening, get on some medication if that's necessary, and be referred on to something if it's needed, like talk therapy. But we really want this to be normalized so that we are having a conversation about behavioral health. So supporting crisis services and outpatient community behavioral health services helps the outpatient system to be an access for people, right? It helps to prevent more intrusive and expensive and deeper end services like hospitalizations and negative outcomes like arrests, and then entering into the criminal legal system and receiving behavioral health services through the prisons. We haven't touched on everything that we do, but again, we invite you, if you'd like, to invite us to take more of your time to talk about this crucial system. And we really thank you for your time. We're going to touch on an even lighter topic next, which is our response to the opioid fentanyl crisis. Evan, I know that we are short on time, but I'm looking and trying to read the room, and I'm thinking, like, could we just do a real quick 2-minute stretch break for folks that have been sitting this whole time, and then dive into opioids?
I am thinking we will, to be respectful of some of our other presentations coming after you, what we might do is let's get into the conversation on opioids. If we need to move a little bit into that break time we had planned, we can do that, and then we can buffer a little bit on the back end as necessary, if that works.
Absolutely, that's why I asked. I will do this though. Hey, if you're on your home and you're on Zoom and you want to stand up, even though Evan said you could. Yeah.
Good morning. As Carrie mentioned earlier, my name is Michael Langer, one of the 2 deputy directors with the Division of Behavioral Health and Recovery. And that's Tisha mentioned under her portfolio. Under mine would be prevention services, opioid response, operational functions of the division, things of that nature. So really happy to be with you here this morning. And also Chris Shera, who is our state opioid administrator, is going to do much as Tisha did and talk a lot of the different strategies we have to address. Initially, we were going to start it off at I think we thought wiser of that maybe we not start off with statistics about fentanyl overdose deaths at 8:30 this morning. So we pushed it back a little bit. Let's see. Thank you for being here in person. Thank you for those that are with us virtually. And we are going to talk to you about the challenges facing too many individuals, families, and communities in our state. Fentanyl-driven overdoses and overdose deaths in general. We'll share some of our cross-agency collaborative work, as well as some recent data that illustrates the battle we still have to support those in need. As you know, many, if not most of us, have been impacted by family or close friends losing loved ones in recent years. And this is in every corner of the state. We also know communities of all sizes across our state and the nation are seeking solutions. Fortunately, we do have some effective tools, and we want to make sure we highlight a few of those with you here this morning. And before I turn the page, I will say, in terms of effective tools, having the medications to address opiate use disorder is a game changer, and one that we want to continue to find ways of using as often as we can for those who are interested. So next slide. Oh, go here. So I do want to, I'll share with you a little bit about our state response plan. As many of you know, back in the turn of the century, literally back in the early 2000s, we were talking a lot about the impact of prescription opioids and what the devastation that was causing us across the state. We did organize across state agencies in the preteens and the early teen years of the 2000s to talk about which agencies are responsible for what strategies are shown to be effective around the nation, and how might we be able to advance those here in the state of Washington. But again, that early organization was around the prescriptions, which moved fairly rapidly back to heroin. And remember the challenges we were having with heroin and heroin overdoses. And now, as we find ourselves in 2023, much of our discussion is about fentanyl. This is far and away the most used opioid right now in terms of in the communities that are driving the overdose deaths. So when we did organize and develop our plan, which started in our first plan, I think we published in 2015 formally, and then have updated a couple of times since, we have a number of areas that we focus on. So we won't talk about all those here this morning, but primary prevention or early prevention services, whether it's getting the education out to young people and their families, or doing some of the take backs of the medications, things of that nature. But there's a whole area of the plan around prevention. Also, detecting and treating, as I mentioned before. A lot of our outpatient and residential FUD providers have been working on opioids as well as other drugs for many, many years. And the boon has been the advancement in to be able to use many of the medications, whether that's Suboxone or methadone or other medications that might be out there. You're hearing about Sublocade now. These are really great tools, and we actually encourage folks to go there first. If you or your loved one are having an issue of this nature, we want to make sure that we offer that medication to you in a timely way. And then, again, working individually, see what kind of counseling or talk therapy or other kinds of things that are out there to support that. So I want to make sure I stress that. That's key and part of the plan. We also want to ensure the health and wellness of people who are using drugs. And so not everyone is motivated to seek treatment immediately, but we certainly want them to live, right? We want to make sure that we have naloxone and other the antidote for overdose available. We want to make sure that folks are using, if they are using supplies, that they're supplies that aren't transmitting communicable diseases, things of that nature. So we want to really tie people into health services as we can. A couple other parts of the plan related to the data, as well as support, make sure we're using good data, and also making sure that we support people in recovery, whether that's housing, employment, transportation, education, childcare, all those things. There are a few of our populations that we have added focuses to as the plan has evolved. which including Alaska, American Indian and Alaska Natives, also those involved in the criminal justice or legal justice system, pregnant and parenting women, and certainly their children prior to being born and immediately thereafter. So those are key foci of ours in terms of populations. And then we have a couple of other work groups related to communications and data itself. Communications, really, we want to make sure we're getting the right messages to the right people. Again, this might be young people who are not involved in drug use. We want to keep it that way. It might be how to intervene early with a loved one. It might be where treatment access is, where medications are, and certainly where recovery support services are. So we want to make sure that we're touching on all of those things. And Chris will go through that here.
Michael, we do have a question in the chat. I recognize we may not, as a result, kind of get to cover everything in the presentation today, but do want to make sure that this is useful for legislators in particular. I think there was a question from Representative Leavitt just around what work we might be doing in partnership with other entities, particularly local public health and schools and school districts in the opioid space.
Thank you, Evan. And the plan is on our website, and we'll make sure you guys get links over to that plan. I have a copy here, but it goes through each of these areas and breaks it out in individual strategies. So as we created the plan, each of these areas have work groups in them, and we work very closely and actually lead this effort with the State Department of Health. And so we have brought our local partners to the table when we said, okay, how are we going to organize around what recommendations we have to put forward in a state plan? Also, just the model of the plan. When we first created this, again, in the mid-teens, that was sort of a prototype that a lot of local health jurisdictions or a lot of local communities and tribal governments used to model after. So they sort of filled it in on their own locally, looking at those sectors to respond to, or those areas to respond to. So, and schools certainly are part. We want to make sure we have good education, good prevention services in schools, and also naloxone. The antidote naloxone needs to be in every school building. Right now, it's required in some of the larger and medium-sized schools, but many districts are choosing to put it in all buildings. It's so important, not only for who's there during the day, but who's there in the evenings on these campuses. Okay, I'm going to go through some statistics pretty rapidly because I do believe that you are hearing a lot from your constituents and are probably reading a lot about fentanyl at this point in time. This particular slide, the next few slides will kind of give us share with you the data that we have now. You will certainly see that the impact overdose deaths driven largely by fentanyl. So if you look at synthetic opioids, it went from 142 in 2017 up to 850 in 2022. That's just we're briefly 1850. What's that? 1850. What is it? I said the wrong word. 1850. I'm sorry. Thank you, Chris. But you also will notice that stimulants has also. We do have polydrug use happening. We have people using more than one drug, and we also notice that the stimulant overdoses have also risen quite substantially. Technical difficulty. Oh, there it goes. There it is. Okay, all right. Just took 8 strokes of the key to get it there. This is another quick chart to show that we haven't bent the curve yet. We're still seeing the rise of the fentanyl and fentanyl analog by quarter overdose deaths. So the green, as you see, or yellow, depending on what your screen will show you, shows for the first 2 quarters of 2023, the bars continue to go off the charts. They're just way too high. And then finally, I wanted to share, this is all drug use, but as you see before, a lot of this is from opioids and fentanyl with stimulants in there as well. But this really shows the populations that are overrepresented. And you'll notice that, again, Alaska Native American and Alaska Native is really high in terms of overrepresentation of death due to overdose, as well as our African American community. And you can see down the line here We've done a lot of work with our tribal partners this last year, trying to actively listen as much as we can to what their needs are. And Chris will talk about some of those strategies. Okay, at this point, I am going to turn it over to Chris. And unless we have any other questions.
Just one question in the chat, and I don't know if we're able to get to it. We might just need to follow up here. But if we know kind of roughly when you're talking about overdose deaths, how many of those are percentage of the population that are children, babies, toddlers, so non-adults? And if that's something we need to follow up on, we certainly
will follow up and get you the age breakouts. Yeah, absolutely.
We do have that information available by age, so we can follow up on that.
It sounds we have about 10 minutes maybe.
Okay, all right, cool. I'm going to talk really fast. Thank you all for coming today. I want to thank all the legislators online as well. Also, just wanted to let you all know that I was junior class president of my high school. I understand the pressure that comes with elected office. So appreciate you all, the pressure that you all have to serve. So, let's see.
That's a different slide.
Yeah. So as Michael mentioned this, the fentanyl crisis is complex. It's increasing in its severity. And, you know, we're continuing to leverage the state opioid and overdose response plan to outline strategies. And those strategies kind of fall into the different categories that Michael mentioned. I do want to mention that we're in the middle of a process where we're working to update the plan. So some updates will be coming soon, although all of the strategies that are listed in the current iteration of the plan are still very relevant. And I want to talk a little bit about capacity, because at the Healthcare Authority, we're always trying to figure out how we can increase capacity. And when we talk about capacity, we just mean the ability to provide an array of services that span the continuum: prevention, treatment, recovery, harm reduction, and things of that nature. And we're also trying to understand how capacity is limited. And there's a lot of reasons that it can be limited. It can be limited by lack of workforce, stigma, resource availability, and the ease of accessing services by the individuals that we're trying to serve. One of the ways that we can increase increase capacity is making these services as easy as possible to access. And you'll hear a phrase, low barrier. That's a phrase that we use a lot. We want to make these services as easy to access as possible. And so we are always looking for low barrier approaches to services across the continuum. We've seen this in providing low barrier access to our hub and spoke and opioid treatment networks. If you're not familiar with those, hub and spokes are office-based opioid treatment programs where we have a central sort of hub that provides access to access for more complex clients, and the less complex clients can be served out in the spokes. So then we also have opioid treatment networks. Those are office-based opioid treatment programs where we require them to provide access to ancillary services in their community. So the network is not just providing the medications for opioid use disorder. The network includes access to primary care services and other services like that. Our hub and spokes and opioid treatment networks have been active for about the last 5 years. The state opioid response is a SAMHSA grant that we have. That's the Substance Abuse Mental Health Services Administration. And in the last 5 years that the hub and spokes and the OTNs have been serving individuals, we've seen year over year increases in the number of individuals served. And they've been operating for a while. They do a good job, and they also do a good job of retaining clients as well. And so that's great. But also not every community that needs those services has availability for those services.
Chris, I'm going to interject just one thing. On the hub and spoke, when it was started, it was because we had individuals who had the waivers to prescribe the medications. but they didn't have the time necessarily to do that. And so we added staff to where the prescribers are, and they became the care coordinators, if you will, with case managers, with their care supporters. And so they help the prescribers get the medications and then refer out to the counseling services or mental health services. So.
Sure, yeah. I want to talk a little bit about workforce. You know, Michael mentioned tribal engagement. As we've engaged tribes and communities across the state, one of the recurring themes that we hear, and this ties into our ability to increase capacity and provide low barrier access to services, is workforce. We hear from communities, well, gee whiz, we just don't have people to hire to do these things. And so that's something that we're very interested in. A recent investment from the opioid abatement account, we took a modest amount of funds from that to establish an SUD scholarship program. So this is for degrees and certifications that are related to the substance use disorder field. And this, you know, the obvious things, tuition and books, things like that. But also, because these are opioid settlement funds, we have the ability to be a little bit more creative. We don't have the typical restrictions that we see with federal funds. And so we're able to, say, provide a gas card to a person that needs help getting to school, or things of that nature, or you know, fees associated with seeking certifications. So it's not just tuition and books. We can be a little bit creative with that. We've started that with about $370,000 of opioid settlement funds, and that'll get it seeded. And so we're in winter right now, going into winter. So by the time we get that set up, is you know, following the next session, and we'll be in summer, and then the school schedule will be starting again. And so that's when we're really going to start to see those funds hitting the universities and community colleges that provide those educational services. So we have a subject matter expert, Steve Perry, who's working on that. If you have questions about that, I would have to direct you to him, but it's great work that we're really excited about. And Michael mentioned our final strategy here, naloxone distribution. The Healthcare Authority, we continue to work with the Department of Health, their Office of Education, and naloxone distribution with investments that you all have made through General Fund State. We also support naloxone distribution with our Substance Use Prevention, Treatment, and Recovery Block Grant, and then also have considered how we might continue to support naloxone distribution with opioid settlements. There's one particular settlement, the Teva settlement, where we're actually receiving naloxone product as part of that settlement. So we'll be increasing naloxone distribution with those resources as well. Next slide, please.
Chris, I may just to be conscious of time, see if there's just a couple of additional comments to wrap things up on opioids and fentanyl, recognizing that we're obviously unable to touch on everything we wanted to cover here today, and happy to follow up with legislators and staff offline on any of these issues. But see if there's, you know, a couple other points that you wanted to hit before we wrap up and give folks a short.
Yeah, I can wrap this up in just a couple of minutes. I'm going to talk about this slide, and then I'm going to skip to my last slide, which is opioid response highlights. And if you have any questions about the slides in the middle, you feel free to reach out to me. But tribal engagement is huge. We're always looking for ways to engage tribes more. Our Office of Tribal Affairs, we're lucky to have Aaron Spark, who leads on this issue. When we were first talking about how we wanted to use opioid settlement dollars, we thought, well, we've got all these great ideas, and then each idea will make sure that the tribes get some of that. And then we had a formal consultation process, and the tribes were like, no, just give the money to us and let us figure out how we want to do it for our communities. And so we heard that in the formal consultation process. And so that resulted in a distribution of $15.5 million. That's just the first. Many of these opioid settlements pay out for many years, some up to like 17, 18 years. And there are 10 different settlements that we're tracking. So this is a journey. This is not a one-time thing. This is something that we're going to be talking about every year. And then I'm going to skip to response highlights. All right, so here, to be mindful of time, I'm going to hit, let's see, health engagement hubs. I'm going to talk about that for a little bit because it's new and it's something that we haven't done before in Washington. So think about harm reduction programs, syringe service programs, things of that nature. Individuals seek services at those places because they feel comfortable there. They have a rapport with those individuals. They're less likely to seek services at a hospital or a clinic in a strip mall because they feel like they're going to be judged. And so what we're wanting to do is increasing capacity by bringing the right services to the right people at the right time. And so health engagement hubs enable us to bring healthcare and primary care services to those individuals in those settings. So think of a syringe service program that also offers medications for opioid use disorder, infectious disease screening, primary care for, the health issues that come with drug use and things of that nature. Some of the more sophisticated ones in the country bring in dentists once a month to provide dental care, things of that nature. So think about all the other healthcare things that an individual might want to access. We're trying to bring that to those individuals in a setting where they feel comfortable accessing those services. And so this is something that we have made some investments in from the opioid abatement account. We currently are working on an RFP for this. So there will be opportunities for communities to request access to funds to establish health engagement hubs. And I could talk for 10 minutes on each one of those bullet points, but I'm going to stop now and see if there are any questions. Evan.
Great. I just want to say thank you. Huge thanks to this panel and all of the folks in our Division of Behavioral Health and Recovery for all of the work that they do, as well as I know we have a bunch of our sister agencies here. There's a lot of great partnership happening across the state government and the executive branch on this. I know there was a question in the chat more directed at our partners at the Department of Health around some of the education and outreach efforts that they've been funded for. So we'll make sure that Senator Wilson, we connect back with our partners to get you some more responses to that as well. So just a huge thanks again for this. There's a lot of material covered, so if you have questions offline, happy to take those. Our folks will be around for those who are in the room and want to chat on our brief break. Right now, what we'll do is we'll give folks a 5-minute break. I know we're going to eat a little bit into our next presentation time, but we can make that up. Please grab some coffee, some snacks, restroom break for folks online. We'll plan to come back here in about 5 minutes, so should be around 9:57 or so with our next presentation. I hate to kill the good banter in the back of the room. But I do want to know we're going to go ahead and get started with our next panel to try and keep us on time. I will also note that our mics are back on in the room, just for everybody.
Mics are good.
So our second panel today, we're going to focus on a lot of work that we've been doing around Medicaid transformation in Washington State. As many of you are familiar with, this work started a number of years ago, 7-8 years ago, with the initial Medicaid transformation project, which is our state's 1115 transformation waiver, and is going to continue over the next 5+ years with the recent renewal of our waiver that we received from CMS. So we recognize that the formal renewal approval came towards the tail end of this past legislative session, and wanted to take some time today to do a bit of a deeper dive on our 5-year renewal and some of the new work that's going to be accomplished by the state, new funding that's coming into the state. So with us today on our second panel, we have our Chief Policy Officer, Michelle Needham, as well as our Medicaid Transformation Project Director, Chase Napier, and they're going to take it away and give you a deeper dive into our Medicaid Transformation Project. So thanks.
Great, thank you, Evan. Let me do a sound check, see if my voice is getting to the back of the room, because I know I have not a very loud voice. All right, I'll try to remember to project, so please wave if you can't hear me in the back. All right, can we go to the next slide? Thank you. Oh, we have control. Just wanted to do a brief introduction of the waiver and the context that it's attached to the overall Apple Health or Medicaid program. And as you recall, this agency purchases both Apple Health and our public employees programs. So we have over 3 million lives that we purchased for. 2 million are in Apple Health today. And the waiver is attached to that portion of our program. believe you will recall we had an 1115 waiver in the last 7 years. I guess it started in January of 2017. And that's a specific agreement with the federal government, Centers for Medicare and Medicaid Services, that allows the state to test specific policies. It has to be something that can be waived in federal law. So there's very narrow margins of what we can test, but we are testing a few different programs to improve services and delivery for the alcohol program. The last demonstration, again, started in January 2017 and just ended June 30th of 2023. And our renewal for the next 5 years was approved on that day as well. We do call it, as Sue noted in the introduction, the Transformation Project is MTP 2.0, because this is a new body of work. It does continue some of the past efforts, but it has a lot of new programs in this new wave. And overall, over the course of 5 years, it represents about $4 billion of enhancements with federal and local funds to support the program. So again, we'll review what we had in the first waiver, since many of you are familiar with that, and it will be the base for what we have going forward. We did have a program called Accountable Communities of Health in the first demonstration, and services with Indian healthcare providers. That program is transitioning, so it is continuing but transitioning. We had services for long-term services and supports with programs we called Medicaid Alternative Care, or MAC, and tailored supports for older adults. Both of those are run out of our DSHS Aging and Administrative Services program. So I should say that many of these programs under the waiver are scattered across the whole agency and other agencies, significantly at DSHS. So we are representing the overarching coordination. Chase leads all of that with CMS. The other program that is on this slide, Foundational Community Services, or FCS, has particular services for helping people maintain and keep their housing and employment. And we have that program continuing with some enhancements that we'll talk about. We also have programs that are continuing that are substance use disorder, mental health services in an institution for mental disease. That allows us to access some federal funding for those services that we otherwise could not access. So those are both continuing. And I will let Chase talk about what we learned in the 1.0 demonstration.
Thanks, Michelle. Yeah, again, my name is Chase Napier. Thanks for being here with us today and for the opportunity to share more about the work ahead. So we wanted to highlight just a few learnings from our first 5-year waiver period and how that impacted our application and what we received approval on. So we're continuing our partnership with our accountable communities of health, the 9 ACH regions across the state, but we really learned that there's an opportunity to focus on the social determinants of health. Health-related social needs is kind of the new framework that's being used across the nation. So more focus on health-related social needs and health equity. The work under our first waiver was really around delivery system reform, and there's some really incredible delivery system reform innovation and capacity building work, but it was very broad in focus and a lot of discretion of across the 9 ACH regions and their partners. And so we really took a look at that and honed our focus for the accountable communities of health and our partnership with the ACHs, and we'll talk more about that. And it does provide more of a focus on health equity and social determinants of health. More partnership with community-based organizations, less focus on the clinical delivery system reform compared to the first waiver. And then, of course, Michelle already highlighted some of the continuing programs. We did find there were some incredible successes with our foundational community supports and our long-term services and supports, specifically the Medicaid Alternative Care, MAC, and the tailored supports for older adults to SOA. So excited to continue those with enhancements. So we wanted to highlight just a couple of examples of some of the accountable community health activities under MTP 1.0. There's a lot of response to the opioid use pandemic and a lot of really incredible efforts with collaboration across sectors with the ACHs. I wanted to highlight one example with 2 of our ACHs where they were installing naloxone vending machines across their regions, and that work continues today. And so, you know, this effort really provided life-saving medication for individuals in need. And another example tied to this idea of the interventions around maternal and child health and addressing healthcare workforce challenges. Greater Health Now in the Greater Columbia region invested in a community health worker internship program to provide training, and the CHW efforts there provided whole person care and care coordination and behavioral health supports within primary care teams. So just a couple of examples of the type of capacity building and workforce interventions and training programs that were provided. And a lot of this idea of the community health worker supports and how that relates to some of the workforce challenges is what we're going to talk about as one of the continuing efforts with our accountable communities of health to support those linkages to community-based organizations and the local workforce. So new programs we want to highlight. We'll go quickly because there are several new programs. The first couple of programs here are really around enrollment enhancements and continuity of enrollment within our Medicaid program. So the first is continuous Apple Health enrollment for children ages 0 through 5. And so this provides continuity of coverage. And this is from age 0 through the first month of the child's 6th birthday. So that's why we use the language 0 through 5. And really important, the coverage, you know, of course, is just the foundation for the care that is so necessary during this 0 through 5 timeframe for these children. The second eligibility policy that's new is the Apple Health postpartum coverage expansion, and this is for the 12 months following the end of a pregnancy. And again, this is specifically for the waiver coverage is specifically for those not previously enrolled in Medicaid or CHIP. We do have a state plan option for those that were already enrolled but needed the waiver for the full scope of coverage there. And then contingency management is a new intervention that we're including in the waiver for SUD treatment. And this is an evidence-based program that incentivizes success in managing SUD. And so we have a partnership with Washington State University. We're really excited about this program. I believe we might be the first in the nation on an 1115 waiver for this program, if not the first one of the first couple that are exploring this. So this was really new with our federal partners, and they're really excited about this as well.
And before we move from continuous coverage for children, I just want to note we have a decision package related to that. We had authorization in last year's budget to expand that coverage for the Medicaid children 0 to 5. And during the negotiations with CMS, they authorized us to also include the CHIP children. So we do have a decision package asking for that small enhancement in our spending authority.
All right, probably our largest newly approved program is the reentry coverage in carceral facilities. This is for prisons, jails, and youth correctional facilities and detention centers, and authorizes us to provide Medicaid services pre-release up to 90 days prior to release. There's a phasing expectation for services. We're trying to get facilities to be able to participate based on readiness. And so there's a mandatory set of benefits, and then there are some secondary benefits. We'll talk through that a bit, but the goal really being we want to support all facilities and participating as they're able to. And the minimum required services are case management, medication-assisted treatment, and then a 30-day supply of medications for the point of release. There's another, there's more detail we'll get into in a few minutes. So in the long-term services and supports, we mentioned enhancements a couple of times to the work we're doing within the long-term care system. And so the first enhancement is expanding income eligibility. So this just enables more of the incredible supports. We determined that we needed to expand the income eligibility limits. And then presumptive eligibility for individuals applying for long-term services and supports. Under the first waiver, we did pilot presumptive eligibility with the waiver benefits, and this was basically just streamlining the eligibility determination process. It really cut down the delay in getting the services that were necessary, and then we found there was an incredible success rate with that streamlined eligibility and enrollment process, and so received approval to expand that to long-term services and supports more broadly in phases. And so it's still piloting to demonstrate the effectiveness and success of those determinations. And then programs that address health-related social needs. This is another pretty large effort that we'll get into more detail on. So the going back to the reentry program, the 90-day pre-release support for services in carceral settings. The mandatory benefits, I know the text is a little bit small there. I already mentioned the 3 mandatory benefits. The 4 secondary benefits are medications during the pre-release period, lab and radiology, services by community health workers, reentry navigators. There are a few different names there, but really thinking of those with lived experience that are important to help the transition to community supports and identification of necessary community supports post-release. And then physical and behavioral health clinical consultations, so healthcare consultations. And so we're working on a process to, again, allow facilities to get engaged based on that minimum set of benefits, if that's where the capabilities might fall initially, and then working towards the secondary benefits. The goal would be to have all facilities providing all benefits at some point, but that's just not expected on day one. And then in addition, facilities, we're going to develop a cohort model where facilities would join over time. And so not expecting all facilities will even offer all mandatory benefits on day one. There will be a readiness process, and there's going to be capacity building funding to help facilities get ready. And our timeline for capacity building funds, again, part of the decision package is the authorization for this program, the 90-day period pre-release, and the capacity building funds that we were able to receive federal approval for. That is really important to help facilities with things like technology. I think we have a slide that I won't spend time on, but the next slide covers a few of those categories that facilities are going to need help with. I think the one that we are very aware of is the technology and IT services, including the EHR capabilities and billing supports. And many of these facilities are new to Medicaid and Medicaid billing, so there will be support provided.
I want to say the reentry, as many of you probably know, is brand new. California is the first in the nation to get approval from CMS for this, and we are the second. It has not been implemented anywhere yet, so we are still working through a lot of details and foundational framework with CMS, and that is going to take a lot of time, what they call a protocol, to have a lot of that design and development work has to be submitted to them, and they will approve that. We are trying to work in tandem with California at this point to make sure that if they get something approved, that we're right in line with them as much as possible, and that CMS is efficiently working with both of us to the degree that they can. But some of that will take a lot longer than some of us might like, and just know that that's part of the process with CMS.
And the health-related social need services, HRSN, again, we're using that because that's the framework that's being used by CMS and other states that are receiving these approvals. We previously talked a lot about social determinants of health, and it's really the same body of work. CMS has provided more flexibility for states, and we're one of the first 5, I would say, to receive 1115 approval for this HRSN framework. For the managed care population, there is the in lieu of services framework, we won't get into detail on, but there is the opportunity for managed care organizations to optionally provide some of these services to their members in lieu of other approved services. And so there's new guidance on that, a lot of changes to that process. But the goal was to leverage the managed care authority where we can, and then to focus the waiver authority and the waiver funding on the fee-for-service equivalent. So that's still our strategy. These phase 1 services are really largely the housing services. So the room and board restriction still applies. Medicaid dollars cannot be used for room and board outside of an 1115 waiver. And we are going to focus on those housing supports. And all of those, again, require waiver funding. So there isn't a managed care equivalent. So for example, rental assistance is one of them that we are so excited about. 6 months of rental subsidies can't be provided outside of the 1115 waiver. And so we're going to prioritize moving forward with that, along with the housing transition services, which is one-time transition costs, first and last month's rent. And so working on how to do the one-time transition costs in conjunction with the rental subsidies for the 6-month period. And then the medical respite is what we call it. CMS calls it recuperative care and short-term post-hospitalization housing. But this is how to get individuals out of the hospital and into temporary housing when they don't need more intensive medical care and supervision. And so we do have some examples of that today, but we'll have additional funding and authority to expand our medical respite provision. And then there's a category on case management, outreach, and education. Again, this is the federal language. For us, this is really that partnership with accountable communities of health and the community hubs to support community-based workforce, community health workers. We use the term community-based workforce just because it's not limited to community health worker certification. And we'll talk more about that in a minute. The phase 2 services, Michelle, I think we don't probably need to get into all of those today, but we'll have more time to talk about those. I mean, nutrition supports, we'll just call out, there's a lot of interest in those nutrition supports under the 1115 waiver. But again, we're considering how to phase those in.
And how we would finance them.
Yep. All right, community hubs and community health workers. So the 9 regional ACHs would administer community hubs, which is really just the infrastructure for the network for community-based organizations that employ community-based workers, community health workers. And one really clear example of where this infrastructure and the community health worker role is really important is the post-release for the justice involved population. So we mentioned, you know, there's an opportunity to provide some of that navigation support pre-released. Post-release, there's an opportunity to use the same community-based workforce, but fund that through the health-related social needs framework, through the community hubs to provide navigation, to provide identification of social needs, identification of resources and eligibility, and then to make those referrals and really partner with those individuals. And that's just one example. This opportunity is much broader across Medicaid, but that justice involved population is just one really exciting example of where we want to apply this new infrastructure. I say new infrastructure. There is some infrastructure today across the state through our accountable communities of health. There were a couple of pilots that started this concept of developing regional infrastructure and networks of community health workers and some of the technology that provides some of the continuity and the glue across community organizations that otherwise can't talk to each other, can't see experience and enrollment and services, and where services were actually provided or not provided. So some of this has been piloted, and then Department of Health through COVID response also contracted with the accountable communities of health for this same body of work to support isolation and quarantine efforts and getting really critical resources out to the community. And so this is really about place-based community workforce that have cultural competence, that have lived experience, that can best help individuals identify community supports that they need and how to get those.
And Chase, just a couple of questions coming in through Zoom that I want to make sure we get to. Representative Schmick is asking And I think it's a great question. How will we measure success? How are we going to think about success with the health-related social needs program, or more broadly with the Medicaid transformation initiative? And I may add to that, you know, as a bit of a retrospective, how did we think about success in the first 5 years, recognizing this is a transformation project? We're piloting new policies in the Medicaid space. So I think it is a great thought for us to
Sure. Yeah. Yeah, I think that's, you know, on the first, just looking back first, I think our measurement framework for a lot of our efforts was really broad. And, you know, our measurement framework for the delivery system reform program was incredibly broad. We see some success there. Obviously, also the COVID impacts really had a pretty big influence on the trajectory of some of our measures. And so we're still, I think, waiting on clarity on what the experience was. Still waiting on our final evaluation results too for the first waiver. On this second waiver, though, I think we are interested in really honing in on some of the interventions that we're going to prioritize, like the housing interventions and the community health workforce supports. So just some practical examples. I think on the slide we're looking at right now, we want to measure engagement. How many individuals were engaged? How many individuals were screened for social needs? How many needs were identified? And what was the success rate for referrals to available programs? And then on some of the actual payment for interventions like rental subsidies, there's a lot we can track there to see the successful continuation of housing and sustainability of that housing beyond the six months of rent. Obviously, we wish we could have gotten longer rental subsidies, but that's the maximum CMS has been willing to approve. And then partly too, this maybe isn't a performance indicator, but a lot of this is based on the medical appropriateness. That's the language that is being used. So there's an assumption that we're providing these services based on specific chronic conditions or specific health conditions that behavioral health conditions that would justify some of these supports. So just to say too that this isn't a completely open-ended menu for implementation. We do have to have some justification around the qualifying conditions and context.
I think, Chase, in that same vein, there was a question from Representative Davis just around whether behavioral health outreach services that might occur prior to formal intake, diagnosis, or treatment might become Medicaid billable for the first time. I think what I'm hearing from you is there's still some complexities there and some tie back to medical necessity. But Representative Davis, it might make sense for us to follow up with you offline with a bit more detail to be responsive. And Michelle, I don't know if you had more comment to that.
I would just underscore what she said, that there are specific medical criteria and limited eligibility components for most of these approvals from CMS. It still needs to really meet their definition of medically necessary care and have some evidence that we'll be monitoring for. We have not submitted our formal evaluation proposal yet. That is coming this winter. So we are still refining that, and we'll get more specific on what we are hoping to measure with their approval, obviously. But it is very targeted still within a CMS framework.
And one more quick question as well before moving off the slide. Senator Robinson was wondering whether all ACHs would be expected to implement the community-based care coordination work.
Yeah, it's a great question. Yeah, and they are all expected to implement this. There, I think, is one region that may have a partner that they contract with because there's an existing regional presence for similar work, but all of that will be managed by the ACHs.
It really is a different framework from the first waiver where we had 1,000 flowers blooming. We had a lot of different things to demonstrate in that first waiver within the ACH projects. And this is a much more targeted, very focused waiver with the ACHs. So they will all be doing the same types of activities and not 1,000 different flowers. So
there's also a native hub, so some similar concepts. I won't, repeat the intent around the functions, but recognizing that there's value in continuing to partner with Indian healthcare providers, really focusing on Native-led, Native-serving organizations. And this would be more of a statewide infrastructure, a statewide network, really designed by tribes and for the Native-led partnering organizations. And so there's efforts within Office of Tribal Affairs to continue engagement. In fact, I think it's happening right now, engagement with tribes across the state on the design of the Native Hub. And then community information exchange, we have the opportunity to support all of the health-related social needs work. So a lot of it's focused on the services, which is the new payment, new ability to pay for the interventions. But there's a recognition similar to reentry that we need capacity building funding, and so there is capacity building funding for that body of work, the health-related social needs work. One of the categories is the technology, which is really around information exchange and getting partners to be able to talk to one another. And so in our conversations with CMS, we talked about community information exchange and the work that we've been doing over the past few years on the design of a statewide community information exchange system. So just wanted to highlight that is part of the opportunity we have to fund through the capacity building dollars under the waiver. And just, quickly, I guess, for what we're talking about with community information exchange is it really is about that visibility across programs. You could have a community record of an individual with their identified needs, whether they need housing, whether they need nutrition supports, whether they are enrolled in a health plan or not, and being able to see that as a community organization to understand the client and their needs, what they do have and what they don't have access to, and then resources of availability of partners, availability of partners that you can refer to, and even track those referrals. So that's what we're talking about, and why it's so critical to have some type of system like this to support the health-related social needs. We wanted to walk through just one example just to make it really concrete. Let's just use John, from Olympia, who's receiving residential treatment facility supports in Tacoma. And upon discharge, that residential treatment facility could use community information exchange to understand housing providers that are available. And so if John's returning to Olympia and needs a housing navigator, that individual working with John in that treatment facility would have access to the network in Olympia and be able to make a direct referral and not have to wonder whether or not John actually receives those services, but could actually check to see and track that there was an actual successful referral made and what services John was able to receive. So that's the kind of, there's that technology required to make that possible or to make it more feasible. And that's really what we're trying to support here.
And Chase, I may add, because this came up on the House Rural Healthcare Tour earlier this interim, that a lot of providers are working really diligently to make those connections today. And they're doing it through phone, they're doing it through informal means, right? And so the community information exchange, I think, as we think about it, is really a supplement to a lot of the work to try and make it a bit easier on providers that are stretched really thin and struggling to make those connections that they want to make for their clients, right? Because they know it's critical to find those services as they're transitioning out of facilities, but it's not the easiest today, right? So a tool that they can leverage.
All right, foundational community supports. We, again, continuing with enhancements. So just jumping right into those enhancements. Eligibility was set at 18 and older. Eligibility is now 16 and older. Really exciting to broaden eligibility for the program. And then under the health-related social needs framework, we're going to really leverage the foundational community supports program for those transition costs. So first and last month's rent, deposits, etc., and then that 6-month rental subsidy. So it's really not separate from foundational community supports. It's really just the authorization mechanism. And then we get to really layer that on to the foundational community supports program and all of that infrastructure and that network that exists today. And then just to mention that there's there's an intersection, of course, with Apple Health and Homes. And so we're really thinking really strategically about the use of the 1115 authority for those one-time transition costs and then the 6-month rental subsidies. But the Apple Health and Homes, it really provides the broader perspective on some of the capital investments that are needed that we don't have the 1115 waiver funding for, and then looking at the housing supports outside of the limits under the 1115 waiver. So thinking really strategically about how do we best leverage all of these authorities and think about the housing supports beyond the 6-month rental subsidies. And of course, we're always interested in working with CMS on a longer term rental subsidy benefit, but they have not been open to that conversation to date. And I think that's because the precedent is pretty well established on only approving that 6 month.
Representative Chop just put in a note, so we'll just thank him as well for getting those programs funded and unauthorized. So that partnership has been tremendous, and we continue to have that close partnership with Department of Commerce. The Regional Community Services Program that Tisha is over and is critically linked with them. Nice picture of our timeline. A couple of
overly simplified timeline of only two of the initiatives. This is the health-related social needs and the reentry. I guess just to highlight that there should be funding available for capacity building starting next year, and that's dependent on the decision packages and some of the inclusions there. And so again, capacity building for community organizations that are going to be involved in the health-related social needs services. So the expansion of the housing supports, supporting providers and technology investments, workforce onboarding training, some of the community information exchange is more kind of statewide infrastructure investments that are important. And then reentry, similarly, getting facilities, some of the planning dollars to understand what the requirements are and how they're going to come up to kind of the baseline on those minimum services and what kind of new technology investments, billing practices, again, workforce training and onboarding. So we want to get those dollars out next year. And that's, to allow us to kind of look ahead to the future service implementation. And for reentry, that's July 2025. So ideally, we're looking at about a 12-month runway from getting facilities capacity building dollars to having our first cohorts coming online with those mandatory services.
This is just a refresher for those of you who sit in the budget world that we have a couple of decision packages over in the governor's office, and will be hopefully in the legislative hand shortly to continue some of this work. We have a lot of the core work with us authorized in last year's legislative budget, but between last session and the negotiation with CMS, some of those need some fine tuning. For example, reentry was not in last year's legislative budget. We didn't have any guess about what that would look like last winter, and we have a better sense of that for both the support services, capacity building funds that Chase talked about, and the administrative needs that we need to support all of this work, both inside and outside of the agency. So we have a couple of packages here to continue that or get authorization to begin spending money for reentry. For the CHIP continuous eligibility, as I noted, the health-related social needs infrastructure is largely an administrative package, including the authorization for the community information exchange. The rental subsidies for Foundation of Community Supports was not in last year's budget because we didn't know that was available. And then the new subsidies package. So there are some packages that we will need some discussions with you during session before we can actually implement those services. And I think that gets to just the resources, and we're available for questions, but we can also Evan will follow up and answer your questions offline or make some additional conversations available because I know we're getting tight on time.
Thank you very much. I do want to pause for a second and just see if there's any questions from folks in the room or folks on chat. We are good on time. We have about 10 more minutes for this panel if there are any other topics we wanted to dive into related to the waiver. And not seeing any through. Oh, sorry.
I just have a question. Sorry, just to clarify around the rental subsidies. So those are not currently being implemented. You're waiting for the decision package to kind of get authorization for that. Is that correct?
We have CMS approvals as well. So the question was around the, are we implementing rental subsidies now? And we need the legislative authorization on the funding. And then the CMS approvals, we have a couple of submissions at the end of this year to outline just who are the providers, what is the eligibility criteria. A lot of that we have ready to go, but the submission going.
Evan, this isn't a question so much as a comment, but I want to thank the legislature and the team. This is innovation. This is transformation. This is changing things from the same old way of just shove people in hospitals or just kind of do things the old way. This is really in the nation. We get called out a lot for y'all are blazing the trail, and CMS with the evidence that continues to hold the ACHs and all the other entities accountable is really showing that this is the right direction. I know there's a lot of people here who worked on this historically, and a lot of agencies. I know the Department of Social and Health Services were pivotal in this, Department of Health, all the partners. But Michelle, you and your team are driving change in this country through this work. So thanks to the legislature for partnering. But this is really important for people to understand the magnitude of how we are reshaping and changing things in the right direction. We're stopping some of the over medicalization and moving it back into other commonsensical, pragmatic solutions like we're about. So thank you, Michelle and team. Cutting edge work.
Thanks, Sue. Appreciate those comments. And obviously a special thanks to Chase, Michelle, and then the rest of the folks in our policy division and throughout the agency who work on the transformation waiver. It's very much a team effort. We should also acknowledge that it is a cross-agency effort. We work really closely with our partners at the Department of Social and Health Services, as well as a number of other sister agencies on implementation of a number of these efforts, and that will continue through the 5-year renewal. So thanks to everybody, and happy to keep the legislature updated on progress on these initiatives. As Michelle and Chase noted, we're kind of in the infancy of implementation and figuring out the specifics of how we progress with each of these components of the waiver. And we know that that's going to take us through the next legislative session into next interim. And so we expect that there's going to be a lot of connectivity with you all as that work progresses. So we're happy to keep you updated and check in as frequently as is useful for you. With that, that's going to wrap our presentation on MTP. We are a bit ahead of time. Thank you for catching us back up this morning. What we might do is take a 10-minute break right now and get started with our affordability presentation at 10:50. Start 10 minutes early and try and maybe wrap us a little bit early today as well. So take a break. We'll turn off the mics for a minute and let folks on Zoom take a break as well, and then we'll get back at 10:50. Thanks. Awesome. So we gave folks an extra couple minutes there to take a quick break. We know that it's a long morning, but thanks for sticking with us. We're going to wrap up our presentations today with hopefully a discussion with you all about healthcare affordability. We do encourage it to be conversational. So as you have questions throughout, please continue to drop those in the chat or ask in the room. We really appreciate the engagement. For the last presentation today, as I said, we're going to focus on healthcare affordability, a big topic, but something that we are really focused on here at the Healthcare Authority, but we're also working really closely on with a number of our partners throughout the state. So we have a panel presentation here with some of our sister agencies. Alongside myself and Michelle Needham, we also have Senior Health Policy Advisor to the Office of the Insurance Commissioner, Jane Beyer, who I know you all know very well, and then Senior Policy Advisor to the Health Benefit Exchange, Laura Kate Seichkin, who also brings some unique experience having worked at the Healthcare Authority previously, and so has helped us in some of our collaborative efforts on this work. So with that, we're going to go ahead and get started. The presentation today, we're going to touch on a couple of things, talk a little bit about cost trends and impacts on consumers, really highlighting those impacts on consumers, but also talking a little bit about impacts on employers in the state. Some of the national and state approaches to transparency and cost containment, and then a little bit of looking ahead. And that's really the piece where we want to make it conversational with you all. We want to hear a little bit about what you all are working on, what you might be working on with your constituents or other stakeholders in this space, so that we can continue to collaborate as we approach the next legislative session. So, kind of goes without saying, this has been an issue that the state and the nation has been dealing with for decades. Healthcare expenditures in the United States have risen faster than the pace of economic growth and have tripled, in fact, from 2000 to 2020. And the rising spending has a lot of downstream impacts, particularly on people, employers, and the state, and really here kind of focusing on your constituents and the impacts on them. So just wanted to orient folks at the start of the presentation with this slide. I like it for the purpose of just sharing that the prices that we pay in the United States don't necessarily have to be, really just sharing kind of how prices for certain hospital and prescription drug services in our healthcare sector don't align with other nations. And we see here that the US tends to pay more for the same services. And you may be asking, well, how does that translate to quality or health outcomes? And we also know similarly that we are not always ahead of the pack when it comes to life expectancy, infant mortality, some of these major health indicators as well. So just want to kind of create that as framing as we talk about what prices and price trends look like in Washington state, that there are others who have at least approached the delivery system. So in the United States, and we've shared this slide in front of the legislature recently as well, but in the United States, we know that healthcare costs have been rising, increasing pretty dramatically since the early 2000s, and that the pace of that cost increase has outpaced other economic indicators. Here you can see kind of as compared to all goods and all other goods and services in the U.S. economy. And we also know that those prices have outpaced wages, particularly in Washington state. This slide kind of pulls from Washington state per capita personal income data, and you can see that premiums both from workers and for their families have grown at rates that have exceeded wage growth in the state. And what that all translates to is unaffordability. So consumers often bear the burden. These are individuals who are purchasing healthcare through commercial insurance in large part. We pulled a couple slides here from a recent Commonwealth Fund study on healthcare affordability. They did a survey of folks throughout the nation. And this is showing how, half of working age adults have said that it's somewhat difficult to afford their healthcare costs. And you see this broken down across market sectors as well. So we know that it is not just one group of individuals. It's not just older adults or younger individuals. It's not just those who are low income, right? There's over 40% of individuals with employer-sponsored insurance and nearly 60% of individuals with individual market coverage who found it difficult to afford their healthcare costs. And we recognize this translates into medical debt as well, right? It creates a bit of a burden, drag on consumers, and their ability to kind of maintain their own finances, and that has downstream impacts on the economy that we want to remain cognizant of as well. So here you see, nearly 1/3 of working age adults reported having medical debt or dental debt they were paying off over time. And from Kaiser Family Foundation, and this is from 2019, so we recognize this figure is already dated, but Americans' collective medical debt totaled at least $195 billion So we know, there have been recent efforts, particularly by the Biden administration, to try and tackle this issue, thinking about the nexus between medical debt and credit scores. So there is work happening in this space that's really important for consumers that are impacted. But we know there's also a lot more work to be done, particularly on the front end, to ensure that they're not taking on that debt. Wanted to share this slide a little bit just to give some perspective on healthcare spending by different sectors. So, you see here some of the different services and types of services that are driving the overall aggregate spending in the United States, with hospital care kind of the largest part of that pie. We know that most individuals who are encountering the healthcare system are encountering it through hospital-related services. We also know that hospitals are kind of growing in what services that they provide through consolidation and other, market-driving factors. So just wanted to share that again, kind of for perspective. I might pause for a second too, just to see if there's anyone else on the panel who as we kind of walk through these slides, I want to make sure it's collaborative. We've kind of walked through our cadence here, but if Laura Kate or Jane or Michelle, if you have any other insights you want to share as well, or kind of happy to continue.
I think this is a great perspective on just kind of the market as a whole, and you can zoom in on one individual area, like the individual market, for example, and see similar trends. For example, we know that a large number of folks who purchase their insurance through the exchange, and a growing number, report to us that they're avoiding necessary health care, like filling a prescription, because of cost. So I think this zoom out, is just as applicable if you zoom in.
Okay, thanks. This is some data that we pulled from the cost driver analysis that our Healthcare Cost Transparency Board had worked through around medical spending changes between 2017 and 2019 by categories. And really, this is just to show a bit of a snapshot of how per member per month expenses for different categories of services have increased over time, right? This isn't kind of new news even within this presentation. It's all kind of sharing the same theme, that these costs continue to rise. And in some instances, pretty significantly. If you look at outpatient services, other professional services, which would include things like clinical services or dental services, right? We see some pretty staggering kind of double-digit percentage increases in a short period of time. And the same is true of pharmacy. We know that within healthcare, there's kind of a lot of interplaying variables that impact a healthcare premium and impact consumer out-of-pocket spending, and that pharmacy is a big driver of those costs as well. And the same picture is true here, right? We have seen the pharmacy costs increase on a per member basis over time. There's definitely some changes to utilization that are taking place over this time, but there's a lot of impacts on, from utilization or unit costs as well. We see the price of a prescription drug showing up. We see new higher cost prescription drugs entering the market, and all of that's kind of impacting what you see here. I'll talk about this briefly, and then I want to make sure, Jane, you have an opportunity to maybe talk to this slide as well. This is really just kind of a way to share how these inputs are driving overall impacts downstream, right? It's pretty intuitive, but we thought that a visual would be helpful to just help us all kind of contextualize what's happening in this space. So, when provider reimbursement, prescription drug costs, health insurer administrative costs increase, that means that health insurance spending increases, right? And then plans have to adjust in ways that kind of meet those trends, right? Premiums can go up, out-of-pocket expenses can go up, deductibles can go up, employer contributions go up, right? We know that large employers in Washington State and small employers are facing rising healthcare costs as well at the same pace that consumers are, and that's impacting their bottom line. And as those premiums go up, particularly for employers, We know that that has broader economic impacts as well around employee wages, profits, tax dollars, things like that. So we know that spending is increasing across the board, and it's having kind of broad impacts in Washington.
And so just sort of bringing it home to Washington State experience, for 2024, OIC has authority to review individual health plan rates and small group rates before they're offered. We have to approve the premiums that the insurers want to charge. And we found that for both the individual market and the small group market, we approved on average rates that were about an 8% increase. And it varied a lot as between the carriers. Many of you have heard about Kaiser Permanente's increases on PEB and SEB, and there are comparable levels of increases in the individual market as well. And when we peel back the onion, we're sort of like, why 8%? What's driving that? So the drivers basically, as Evan indicated, were increased utilization of health services, some of it because of pent-up demand from COVID, when we all put off things in 2021 and 2020, and then also increases in price. So it's what's paid per service. And as Evan indicated, my simple formula is, when you think about healthcare costs, what is it? It's the product of two things, utilization and price. And so both are equally important in that equation. And the other driver that we saw, as Evan indicated, was prescription drugs. So pretty similar to what's happening on the national scene. Folks often ask us to, how does this influence, or what happens in terms of like insurer reserves and insurers' margins? And in the rates that we approve, we'll look at, an insurer will ask us to have a certain percentage of premium allocated to build their reserves. And we'll look at what their reserves are in terms of what we'll approve. Generally, it's about 1 to 4% of premium. And I mean, I guess the only other thing I do want to note is we're also concerned about access to care at the same time that all of this is happening. And so many of you know that OIC has been very, very focused on access to behavioral health services over the past several years. And we just released a couple of weeks ago a consent order that our office did with United Healthcare Insurance Company, so United Healthcare, related to their compliance with federal and state behavioral health parity laws. And one of the issues that's identified in that consent order is that behavioral health providers, when you look at the percentage of Medicare that they're paid, tend to be paid less than medical surgical providers. And so here's an example where we are all hearing over and over again about the challenges of accessing behavioral health services. We're hearing about behavioral health providers going out and setting up their own practices and just saying, I'm not going to deal with health insurers anymore. I'm just going to do a cash practice, which really hurts the people who can't pay out of pocket for a mental health visit. And so when we're thinking about cost drivers, we always want to be mindful of where would we want to spend more. So, and I think access to mental health services is probably just about at the top of that list.
Yeah, and I think it's a great example of how, as we talk about affordability, we do really want to remain cognizant that there are some very legitimate policy conversations about access, also quality of care. Behavioral health services is certainly top of mind for us at the Healthcare Authority as well as a purchaser in the commercial insurance space with our PEB and SEB programs. The same is true of prescription drug benefits. We know, for example, for retirees, prescription drug access is really critical, particularly for our UMP kind of Medicare retiree programs, and that we can't just kind of cut off access to those services, and we know we have to continue to include those benefits for those populations, and those have impacts on costs. But just trying to kind of keep that all in mind when we think about sustainability, really, how do we ensure that consumers can continue to afford their care over time as costs increase and outpace wage growth, and we see medical debt increase, kind of what's the inflection point? What's the breaking point with the system? And that's something we're hoping we don't get to, but we want to remain cognizant of. I also see we have a question in the chat from Senator Cleveland just around impacts of inflation on increased prices. And I want to make sure I give kind of Jane and Laura Kate an opportunity to respond here. I think I would just start by saying, a lot of these trends existed before the recent inflation hikes that we saw as part of COVID. So we recognize that broad economic inflation, wage growth, growth in costs for goods and services that are inputs for the healthcare delivery system are drivers of cost, right? And we're probably not even seeing those impacts right now. We'll see those impacts over time as provider contracts get updated for healthcare systems, and that then trickles down into the delivery system. But a lot of those cost trends and a lot of that cost growth has predated some of the recent economics. So I think that's something that we're keeping in mind. But I don't know, Laura Kate, Jane, if you have any other comments there, just kind of around the impacts of inflation and what we're seeing in the market.
So one thing that we'll note is when we were reviewing health plan rates for 2024, the data that's based on in part is 2022 experience. And so what happens is our actuaries, we have a whole team of actuaries at OIC who we greatly respect. And when they're reviewing, they're looking at 2022, and then they're looking at what the insurers tell us they anticipate the trends are going to be. So in looking at anticipating those trends, that's clearly a place where we would consider the impacts of inflation and what they're seeing. But Evan is correct that also remember that often contracts between insurers and providers are multi-year contracts. They could be a 3-year contract, they could be a 5-year contract. And so sometimes when contracts are renegotiated, right, when there has been inflation, it is indeed the case that they'll be, the providers will sort of want to be catching up for the inflationary impacts that they've experienced.
I think that's right. Yeah, and part of it too, what we might see is, right, there has been a lot of wage growth, recently, and is that going to change some of those trend lines over the next couple of years? I think a little bit of that yet to be seen, but as Jane pointed out, right, the data is kind of catching up to experience there. So probably more to come, and Senator Cleveland and others happy to continue to engage you on that question, because I think it's top of mind for a lot of folks working in this space. And Jane, I'll turn it to you too to talk about rates.
So we really wanted to just try to illustrate what's the cumulative impact of these increases, because even if from year to year 6% doesn't seem like that much, or 3% doesn't seem like that much, if you look over a 10-year period from 2014 to 2024 in the individual market, for somebody who doesn't get a subsidy from the federal government on the exchange, or for somebody who's purchasing a health plan outside of the exchange, we're talking about premiums doubling from $295 to $628. And that's a big impact on somebody's pocketbook. And the question also is, what are they seeing over that time in terms of the deductible trends and the cost sharing trends for their benefits?
Great, and I think we may have a question from Senator Fortunato, if you have your hand raised.
Yes, thank you. Years ago, before Obamacare, our company had a good medical plan for our employees. And I can't remember what the number was, but I'm just going to say $1,100 a month. And then we followed the model that was actually done by Whole Foods. What Whole Foods did was they gave all their employees a $2,500 catastrophic plan. So it paid $0 up to $2,500. But then what they did was they gave each employee a $2,500 health savings account. Now, what that did was and I'm going from what he said at a forum, that it dropped their healthcare insurance from $1,100 down to $358. And then they paid, a health savings account of $2,500, so that's another $200 a month. So that meant for $550, that employee had a 100% coverage. Now, when I asked some of the healthcare providers, how many or insurers, how many claims do you have that are less than $300? And the answer I got back was somewhere around 80%. So that means 80% of the healthcare insurers' costs are related to you getting your $57 prescription, your $127 doctor visit. All those lower cost items are adding to the significant cost and overhead by that organization. So, and I make the references, you don't buy car insurance to change the oil in your car and get new tires, you buy it for a catastrophic event. Is there a possibility of going back to that model where you would be able to have and I think Obamacare put the kibosh on this, and I'm not quite sure. So if you can clue me in, and I had to come in and out of this periodically during the morning, but is it possible to get, let's just say, $2,500 catastrophic plan, and then supplement that with a $2,500 health savings account? Is that something that can be done?
Yeah.
Because, and if I could verify that, the problem is the person getting the service isn't the person that's paying the bill. And so I go into the doctor, and the doctor says, you need this surgery, you need this or that. And the typical response is it covered? They don't ask how much. And I use the example of my wife went into the hospital. She was having what they thought was a heart issue. And the doctor wanted to go in and put in a scope her heart. And she goes, how much is that? Like $16,000. Well, isn't there another way that we could check this out? And the guy goes, well, you could do a treadmill, which is $150. So that's an example of just asking how much. So getting back to it, can we do a catastrophic with a supplemental health savings account? And is that something that could be considered somewhere along the line?
So, Senator, high deductible health plans that have accompanying health savings accounts are still very much alive and well post Obamacare. I'll get you the numbers. The Kaiser, well, it's now KFF, it used to be the Kaiser Family Foundation, does an annual national employer health benefit survey, and they have great data in that document about average deductibles and premiums and the use of high deductible health plans. And the use of high deductible health plans has actually been growing. And yes, employers do have the opportunity to upfront put funding into their employees' health savings accounts. I think on your second question about, are we motivated to ask how much? Over time, deductibles in health plans that we get as employees have been increasing, especially for small employer health plans, because small employers are just so squeezed in order to afford health insurance for their employees. And so as those deductibles have gone up, I think consumers have gotten more and more sensitive to, if I go and I do the expensive thing, holy cow, I'm going to have a $1,200 bill right off the bat, and I can't afford that. And so consumers, I think, now are a bit more motivated. Also, when cost sharing is based on co-insurance, like, yes, we'll cover 80% of the cost of this. Well, 80% of that $16,000 procedure is going to yield thousands of dollars in co-insurance for that employee. Whereas if they did the treadmill for $150, 20% of $150 is a lot less money. So I think the onus is on us and the onus is on providers to be able to say to people, yep, this is what this is going to cost. I want you to call your health plan before you decide what you're going to do and find out how much your cost sharing for this is going to be. And I think it's what you talked about that yields and consumers' lack of awareness about what's the difference between a fixed copayment and coinsurance that yields some of the problems that Evan talked about earlier around medical debt, is that we don't even understand how much we're going to get billed for a service. So there's a ton of consumer education that needs to go on, and that not only we need to do, but the insurers need to do as well.
So, you know, it was an interesting experience that I had. Is I had to have a minor surgery. I go in, the guy says, hey, you know, you need this minor surgery. And I simply asked him how much. And he looked at me shocked. You know, what do you mean how much? Right? And so he leaves, he comes back and he says, well, my fee's like $1,800. I said, well, how much if I just pay you cash? He goes, I don't know. He leaves, he comes back, he goes, well, if you pay cash, $1,400. So, but here's the hospital codes. You need the operating room, blah, blah, blah. So I call the hospital. I said, how much? And they said $11,000. I said, how much if I just pay cash? They said $7,000. So I started calling around hospitals. And the cheapest hospital was actually Overlake, right? And Overlake, well, how much? $7,000. How much if I pay cash? $3,500. So I go to I find a surgeon at Overlake. I go and I say, how much? He says, $1,400. But if you do it on Tuesday, I do it upstairs in the private surgery center, and I don't have to give the hospital a cut. It's only $900. So, well, how much is that? Go upstairs, $3,000. How much do I pay cash? $2,000. The long and the short of it is, I got the whole thing done for $3,200. Put it on my Cabela card and got Cabela points. But the price ranged from $3,200 to $22,000, and the only difference was how much. And we need to be educating consumers to be asking these questions.
Thanks, Senator. And I think it's a great segue. Going to turn it over to our colleagues at the Health Benefit Exchange to talk a little bit more about what customers are paying for services and why they're paying more.
Yeah, thanks. And Jane talked about, you know, these increasing premiums year over year since on the individual market, since really the inception of exchanges. It's not just premiums that are increasing year over year, but it's also the cost of health care for exchange consumers. Exchange consumers are these consumers that are receiving coverage and care through the exchange who don't get it through their employer. So really the exchange is serving as the safety net. And what we're finding and what we're seeing through data, which you can see here, is that exchange customers are really disproportionately impacted by the costs of healthcare services. If you look at this slide, which is 2014 to 2020 data, really that dark blue dot that's largely, you know, on the left hand side is what hospitals are being reimbursed for an average consumer who's receiving their coverage through the commercial market. Exchange customers are paying 35% more than that when they receive hospital care, whether it's inpatient or outpatient. And they're really represented in that light blue dot that's generally on the right. And you know, this creates access to care issues. It creates, you know, not being able to really get those necessary services. And so we're really taking a look at what can be done, what the experience is for consumers when it comes to the price of health care that they get through their coverage, as well as these, you know, hospital services and the prices for them. And we're submitting a report next month that really talks about the impact of rising healthcare costs and hospital costs on exchange consumers. So happy to talk more about that later, or later this month.
Thanks, and wanted to also share, as we're talking about kind of trends in rates, some of our experience with the PEP program. We obviously, not shown on the slide, administer at the Healthcare Authority the school employee benefits program as well. A smaller snapshot given the length of time that program has been operating. So kind of really wanted to focus on trends over time. So giving you kind of what's our experience with PEB, obviously some similar trends in recent years with the SEP program as well. But really what you see here is kind of our net funding rate. So that's what we as the state pay, in addition to what consumers pay, what employees and their dependents pay for premiums, and how that has trended over time. Largely the kind of the same concept here, right? We've seen increases from a funding rate of just over $790 back in 2014, upwards of $1,200 as we project out to 2025. So our rates are now kind of current through fiscal year 2023 in this graph. But similar trends, this is being driven by utilization, it's being driven by input costs, unit price impacts on prescription drugs, increased costs on the hospital side and on physician services as well. So kind of just mirroring some of what's happening, but did want to make sure we share it because we know it's really salient for you all as legislators and staff supporting that work as you think about the state budget and budgetary impacts associated with these cost trends as well, right? It is impacting your constituents. It's also impacting state taxpayer dollars as we think about this. So with that, we're just going to kind of transition to some of the active approaches that we have been working on and that the nation has been working on around cost transparency. So I'm going to turn it over to Michelle Needham to walk through some of those efforts.
So now we gave you all the bad news about price increases. We wanted to say that there are some efforts underway across the nation. Here are some examples. There are all-payer claims databases that help capture all of that information and make it transparent for consumers and purchasers. There are several states that have cost boards that set a benchmark for growth, including Washington State. There's a No Surprises Act that helps with the surprise billing, and an Inflation Reduction Act focused on some Medicare prescription drug negotiation, some hospital and payer price transparency requirements. So again, there's data available for some of that, and some public option programs. And then just as a snapshot of some of those activities, specifically in Washington State, we also have some reporting on prescription price transparency, some specific reporting that Department of Health captures on a lot of hospital financials. We have an all-payer claims database here that the legislature established that allows us to draw this information and show you what the cost driver experience is. We have a cost transparency board. We'll talk about that in a minute and some of those efforts. In a recently passed prescription drug affordability board, they met for the first time this last month. We have Cascade Care in this state, which is the public option program that's offered through the Health Benefit Exchange, has some affordability tools attached to that, and some balanced billing protection acts. So these are just samples of some things that we do have underway in this state today that help influence some of that affordability conversation.
And I think quickly, it's just a good plug for all of the great work that is happening in Washington. And I think we jointly all participate in national conversations with other states around work that's happening in this space. And we're not always on the forefront, but often we are. And it's great to be able to share the story of some of the policies that have been put in place in Washington State with a lot of the work being done by legislators in this space in collaboration with us to advance particularly transparency efforts and the data and analysis that affords us in Washington. I behoove us to say we're not grateful for that. So just want to kind of state our appreciation as we kind of continue to talk about some of the work that's taking place, even though we know there's still a lot more work to be done.
So we wanted to highlight a little bit about the Healthcare Cost Transparency Board and the charge the legislature has assigned us. in establishing that healthcare cost growth benchmark or a target for growth, target percentage for growth, and then analyzing those healthcare expenditures annually and identifying some of those trends and what is the driver behind those trends. And then finally, of course, identifying some strategies that can help address that growth. This is a sample of the data stream, if you will, that we have underway within the cost board. Today, we have a focus on that cost growth benchmark or ceiling target, performance against that benchmark. So measuring across the whole state on an aggregate level, what sort of growth there has been. Has it been a 2% growth, 10% growth, 3% growth, for example? We'll talk about that in a minute. But I should stress that the cost board is capturing statewide expenses so that it's, although it's housed within the healthcare authority, it is about all healthcare in the state. There's a focus on that cost driver experience, and some of the slides you saw earlier were related to that. There's also a new legislative assignment around monitoring primary care measurement and seeing if we can increase the percentage of care that is delivered through primary care, with some recommendations on how to do that coming in the next legislative report. A lot of focus on the hospital cost and profits, since that's a really big center of expenses, as Evan noted in some of our earlier slides, and a new analytic support initiative that we have underway. It's kickstarted with the University of Washington. Help supplement some of this analytic work. And then finally, a hope that we do a little bit more focus on consumer impacts and that affordability specifically to impact consumers and make sure they have access to health. As I noted, the board has set the cost growth benchmark. And I should say Sue is in the room and she is the chair of the board. So if you have some questions, she can help answer some of those as well. The board did set some targets for growth, currently a 3.2% growth target. We are monitoring that performance for our first baseline historical period right now. We'll be able to release that soon, hopefully, and then start monitoring against those targets as we go forward. But they're always a couple of year lag because, as Jay noted, the experience that we monitor is based on full claims, and so you have about a 2-year lag to capture that in healthcare expenditures. We also have a new prescription drug affordability board that just kickstarted, and that will really focus on the prescription drug side of those cost drivers. There's a few of those in the nation as well, but just really getting started and thinking about how they might set some upper payment limits. Anything you want to add on prescription drug board?
Yeah, I think this is another space where, Washington has definitely been out at the forefront of state level work on prescription drugs. And I think there's been a lot of contemplation about what levers the state has, policy levers the state has to try and understand and then control prescription drugs. As Michelle pointed out earlier, we have prescription drug price transparency efforts that have been implemented since I think roughly 2019, where we're tracking to a better degree what's happening with prescription drug costs. And this is kind of the next step of that work to create a board where they're having some consolidated conversations about prescription drug costs, and then inevitably with the goal of targeting upper payment limits for those highest cost drugs that are impacting state consumers. So as you can see, we're one of just a handful of states that are starting this work. But we're not first. We're going to have the opportunity to learn as we progress from collaboration with those other states. And we know it's going to be a slow process getting that board's work started up, but we're excited that it is started. I think the first meeting was just earlier in October, with the second meeting coming up in December.
We just said all of that history. And then we have some discussion about Cascade Care over at the Health Benefit Exchange.
So this again is kind of thinking about some of the places where Washington State is innovating. This is one of those areas. So Cascade Care is the primary affordability initiative for the individual market. So when we think about those increasing premium rates that Jane talked about. This is really intended to meaningfully lower those for customers who are purchasing their health insurance through Washington Health Plan Finder and through the exchange qualified health plans. So this includes public option, which again is another first for Washington State. The legislature established the first in the nation public option program in 2019, and it launched in 2021. And that's really where we're looking to meaningfully lower those premiums while maintaining access and quality for customers on the exchange. And the two levers that we have, through public option really are these legislatively mandated provider reimbursement requirements for the public option plans that are intended to pass through to premiums. And then we've been sort of talking about the power that employers and large purchasers like the Healthcare Authority has in order to shape or help influence, I guess I would say, some of the costs of care and the cost of insurance. While the Healthcare Authority can't actively negotiate rates for the individual market, Healthcare Authority is actively selecting the carriers that can offer public option plans on the exchange, and they're really selecting them based on that quality and the affordability. So that's creating a lot more healthy competition on the exchange while also lowering premiums is the intent there. And if you go to the next slide, public option is showing promise. So we, as I said, are doing a variety of legislative reports this year. Several of them zero in and focus on the impact of public option on consumers and on hospitals and on the market overall, as well as look forward to potential future opportunities for strengthening public option. There's a lot of good news here. As I said, we're first and we're learning a lot. As you can see here, that relative to the rest of the plans, qualified health plans on the exchange, public option plans are, those premiums are increasing at a lower rate than other qualified health plans, which again is a lot in part to those provider reimbursement rate caps that the legislature established, as well as the Healthcare Authority's really active selection based on premium affordability. We also know that customers who are enrolled in public option plans, their out-of-pocket costs for medical services are lower, again compared to other qualified health plans that are not standardized. Which again, great news. But these plans are still expensive. We're not seeing meaningfully lower premiums statewide. So there are opportunities that the exchange in collaboration with OIC and HCA are exploring in the direction of the legislature to meaningfully lower premiums and potentially capture funding in order to invest in more affordability programs. So Joan Altman and I are happy to chat more about that in the next month or coming months.
Oh, oops.
So
Thinking ahead, yes. So here we go.
So I think this is me. So the legislature over the past couple of years has been very busy in asking state agencies to submit reports on a variety of issues. And we were trying to figure out how we could sort of visually help folks understand everything that is coming. And so as an example, we've got, OIC's work on rate setting. We've got the Healthcare Authority's work on setting Medicaid MCO rates, which have major impact on the state budget. HCA discussed the drug transparency program, and there was a report that just came out there. So really, I think by the time by the end of this year, there will be a lot of additional information that is going to help the legislature think about, okay, what are we spending? What are we spending it on? And what direction are we going in? I'll just do a couple of call outs on OIC reports. Given all of the concerns that we've heard about access to behavioral health services, by the end of this month, we're going to have a report that looks at all payer claims database information, that looks at access to all mental health services, so crisis services, non-crisis services, how many people are using them, how many of them are in network, how many of them are out of network, what's happening in terms of use, and equally what's happening in terms of price. So we think that will be of great benefit, and we're breaking it out by kids and adults. So we know there's been a really, really big focus on access to mental health services for kids. So we hope that information can really inform the debate. And then on December 1, we'll be submitting to the legislature a preliminary report that was directed in the budget, and it will really focus on two things. We hear a lot about what's going on nationally around healthcare consolidation and what the impacts of consolidation are, not only hospital consolidation, but also what health insurers are doing. And so what we want to do in that December 1 report is basically say to the legislature, this is what the business of healthcare in Washington state looks like. This is how many independent hospitals we still have. This is how many independent physician practices we still have. This is how many insurance companies own PBM, pharmacy benefit managers, and own medical practices, just so that we're all working from a same kind of level setting perspective. And we think that'll be really valuable. And the other thing that report will do is along the lines of what Michelle and Evan and Laura Kate have been talking about is, okay, what could be done next with respect to trying to get our arms around healthcare costs? And we really see this report as basically a baseline that'll help inform the legislature's decisions. And we will be able, in the final version of the report, to do a deep dive on a subset of those policy options. So the actuaries go at it, the economists go at it, and they tell us what would happen in Washington state if we were to implement policy A or policy B or policy C. So we really hope that report can help inform legislative deliberations in 24 and in 25.
And we'll just echo that, we appreciate the OIC's collaboration in these efforts, and that, it's taken a large team, I think, to assess what's happening and where do we go from there. And we're, keeping lines of communication open across sister agencies, and also the Attorney General's office being heavily involved in that report. So
I should mention that the Attorney General's office is going to be focusing on merger and acquisition and antitrust issues, and they're also going to be focusing on provisions in contracts between insurers and providers that do not incentivize competition.
And then I just wanted to mention that we have some additional analytics support coming to help with the cost board work. We recently, recently received a grant, a 2-year grant from the Peterson Center on Healthcare and the Gates Venture Foundation that will help support this contract with the University of Washington and the Institute for Health Metrics and Evaluation. So they are going to do some additional analytic work on those cost drivers. And then this was just a reminder of as those impacts of cost drivers hit the system, they also hit our consumers in lots of different ways. And that influences how we talk about the options that will both show up in Jane's report. They show up in some of the health benefit exchange board discussions. They will show up in our cost board discussions and some of the analytic options that we will all be really spending a lot of time, 6 to 8 months, for these upcoming legislative reports, and getting the board and others engaged in what are the options the legislature can consider and help us dive further into beyond price transparency. We do have some of that, but we all know that price transparency in and of itself is not going to contain costs. It is a tool, but it can't drive down all of the costs by itself. So these will be discussions coming. And I will put in a plug here on this that some of the work also to support the cost board will be in a decision package that we've submitted to help us add to the 4 FTE that you support on that cost board now. Do all of that analytic work to additionally support the analytic capacity and have it not be such a manual process today. So that's under consideration in the governor's package right now.
And then in terms of what we know is coming up, on October 1st, the Office of the Insurance Commissioner submitted a report to the legislature related to ground ambulance balance billing. We've done great work. Thank you so much to the legislature for all the support on trying to keep consumers out of the middle of disputes between insurance companies and providers. And the one missing piece is protections for consumers around ground ambulance services, where we did research looking at the state's all payer claims database, and consumers face potential balance bills of $500 to $1,000 for a single ground ambulance transport, and that's not okay. And so we submitted a report to the legislature October 1 that has a set of recommendations and findings, and we are really pleased that Representative Riccelli and Senator Cleveland and Senator Rizal and we're hoping to hear from Representative Schmick are on board to put a proposal before the legislature. We are very, very heartened by the fact that everything that's been done around balance billing in Washington State has been fully bipartisan and bicameral, and we are hoping that we can have the same approach and plug this last hole consumer protections for balance billing.
Thanks, Jane. In this slide too, I think it's helpful to note that it is a preface, right? As Jane talked about, there's more work coming in the balance billing space. We know that there's more price transparency work coming down the pike in that we have some reports that are going to do some deeper dives into some of these policy options. We expect that they'll kind of belly some very hard conversations, right? Like these are kind of uncomfortable conversations in some respects when we talk about reimbursement, when we talk about prices, when we talk about impacts on consumers, and trying to stay conscious of impacts on access and quality at the same time, and that it's hard work. We do really appreciate the legislature's engagement and willingness to engage in this space. As I stated before, we're not alone, right? We're working really closely with other external partners, with other states, to learn from them, to share experiences with them, to try and be creative. We also want to hear from you too. So I know we have about 12 minutes left with this presentation, and that was part of the intent. We wanted to save some space to hear from legislators, from staff about work that they might be engaged on that is in or around healthcare affordability. If there's anything you're hearing from constituents, issues you wanted to raise with us, happy to make it a conversation. Happy to get you out of here early if there aren't any of those questions or comments. But we'll pause for a second, monitor the chat, and see if there's anything that might be top of mind that we could talk about a little bit more. Or anyone in the room as well.
Hey, got my hand up.
Okay, Senator.
My grandson actually has a unique disability where he's one of 1,100 people in the entire world that his brain doesn't tell him to breathe, which means he has to be monitored 24/7. And you're talking about respite care and all. I have no idea how my daughter is even staying alive, to be honest with you, because she's watching him 24 hours a day. She has nursing help for multiple nights, but what she really needs is additional hours for that additional care during the day where she would be available, but somebody could watch the kids. Now, does that respite care apply to that? And do we have anything on the books for these really unique situations? I mean, he's one of 1,100 people in the entire world. So it's not like this is, something that's out there that's very common. So she needs more hours. And do we have something that deals with these things that are what I guess we'll just stick in the category of rare diseases? Do we have anything that zeroes in on that?
At a high level, and I'll pause to let my colleagues respond as well. And this may be something that makes sense for us to follow up with you offline, Senator, but we know that conversations about rare diseases, innovative treatments for those diseases kind of come up year over year. In the affordability space, right, it tends to be a balancing act, right? Insurance has never and probably will never cover everything, every dollar of service. But at the same time, trying to be cognizant of like, what are those services that are most critical? What is medically necessary? And how can we ensure that, folks are provided those services? Coverage for that will vary depending on the type of plan, the type of benefits that any individual would have. So there's probably some uniqueness to your family member's circumstance that I don't know if we'd be able to speak to here. But Jane, in particular, if there's anything else you wanted to add, and then also want to acknowledge Representative Callan, I think, has her hand up too.
Senator, we're happy. There's so many questions, right? What's the source of the coverage? Do we need to bring in our partners at DSHS who manage the long-term care programs? So we're happy to try to get more information.
Yeah, is there a single point of contact, if you will? It's somebody that has these types of issues, they can simply call and say, oh yeah, we got this program, that program, whatever.
The short answer is probably not, to be frank, right? It depends on what the questions are. And as Jane pointed out, if it's questions about long-term services and supports, if it's questions about Medicaid, commercial insurance, right? There's definitely some specifics to any individual circumstance. If you do have those questions, though, we're happy. Please feel free to shoot me an email, or I would say, the same is probably true for Jane or our other legislative liaisons that work for our sister agencies. We do talk amongst ourselves, and when we get specific questions like this, we make sure we try and manage it across agencies and get it to the right folks. So we can definitely help you navigate that a little bit.
Okay, can you send me an email with contact info?
Of course. Yeah. And then
thanks for your time.
Yeah, of course. And then Representative Callan, I think you had your hand up as well.
Thank you very much. I was trying to figure out how to put all this in chat. I wasn't quite sure how to do it. So thank you for letting me do it this way. I've been having a couple of conversations with some of my colleagues and OIC, and is in response to hearing from providers that are in my district and outside of my district, in particular, those that are providing services in neurocognitive behavioral health in children, families. So it's like, the perinatal 0 to 25 age range. And the increase in their carrier rates and their employer plan costs and the expenses that they're sharing versus the reimbursement rates that they're getting from carriers for the services, and the anecdotal data that they're gathering is seeing very flat reimbursement rates coming in the door for the services that they provide. So I know, mixed in all of your landscape here in the affordability studies and what that looks like, there's this trying to get at this transparency of what that looks like, but just wasn't quite sure where and what in these aspects, that element specifically of do we know if there has been, and when you're looking at rate increase authorizations for our private carriers, how much they're reimbursing the providers for a given service is actually part of all of that, and how do we track that, and what's the transparency around that, and all of that good stuff. So speaking on behalf of my providers, I guess.
So the best transparency around that for commercial health plans is the all-payer claims database. And we had, as an example of how we can do that, we had the On Point, which manages the all-payer claims database, do an assessment of overall healthcare cost drivers for the commercial health plans that we regulate. And Representative Callan, I know we've had this discussion, right? We can't regulate the plans that are self-funded, that 2 million people in the state get their health benefits through, other than the legislature setting the policy for the PEB and SEB uniform medical plan, which is a big self-funded plan. I think it's about 350,000 folks. But when we asked On Point to do that analysis for us, looking generally at mental health, right? Remember what's cost? It's utilization and price. And what we found in that study, at least from 2016 to 2019, was that for inpatient mental health services like hospital services, utilization was relatively flat, but price was up by about 30%. But then when we looked at outpatient mental health services, it was the opposite. Utilization was up about 30%, but price was flat. And so one of the ways that we've been addressing this, because we generally don't regulate, other than Laura Kate's example of the public option, the legislature generally doesn't regulate the rate that a private health insurer pays a provider. But what we can do is make sure that the way that insurer is setting their rates for mental health providers meets behavioral health parity requirements. So are they setting rates comparably? And that's one of the issues that came up in the United Healthcare Consent Order that we just released. And the report that we'll be putting out at the end of this month is going to look at mental health utilization and price for a 5-year period from 2017 to 2022. So that will also, I think, help inform, okay, what does the data tell us about how much outpatient mental health providers are getting paid? So hopefully that helps a bit.
Thank
Yes.
you. Oh, sorry.
Thank you. I'm sorry, I didn't want to just thank you, and also appreciate that we recognize that there's just different power of contract negotiation between independent providers and very specialized, providers in that space, and just want to appreciate, I know I've had these conversations with Jane, appreciate me bringing it to this forum to try to spread the awareness. So thank you. Thanks, Evan.
Of course, Representative. I want to be conscious of folks' time at this point. If there are additional questions from legislators, I think what we'll say is we're happy to always take those offline. I'll make sure that everybody has my contact information if you don't already. We were tracking questions throughout the chat today, so we know we owe a little bit of follow-up to folks after the fact. What I might do right now is turn it over and see if our director, Sue Birch, had any kind of closing remarks for folks, and then we can get you out of here on time today.
I just want to thank those of you that have hung in with us the whole time and those online. I think, as you can see, this work is so critically important, very meaty, takes lots of cross-agency participation. Some of that cost containment work, other states have dedicated like 100 to 120 staff members to just focus in on cost containment and affordability. We function right now with 4. And it's just, all of these topics we covered today require a lot of that cross systems and, subject matter experts and all of the commensurate analytics. So we're going to keep after it. We're going to keep working with you and keep collaborating. We want to hear your great ideas or what you're hearing out of some of your forums that you're attending nationally. And yeah, please reach out to us, and we look forward to a good session with everybody.
Thanks, Uncle. Thank you.
We do have, are we done online?
We are gonna go ahead and wrap up, and I just want to say just really quickly thanks to all of the legislators and staff that participated through Zoom. Special thanks to folks who you get gold stars for coming in person today, but we do really appreciate your attention to our work. We know it was a lot. It's really dense material. But thank you, and as always, let's keep the conversations alive as we get close to session.
One thing we have been monitoring, unfortunately, for those of you that are in the room, we have at state agencies been under some First Amendment visits, and we have had a person who is now circulating kind of out externally, but you may be approached as you leave. So we